Good afternoon, everybody. I'm Dr.
Abhinav.
Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. And on behalf of everybody at AMOG's, I'd like to welcome all of you,
Money with
distinguished
work.
faculty, as well as the audience, to this beautiful program, which has been conceived and executed in association with our scientific partners, Science Integra, through the TOG webinar platform in association with our education partners, Bharat Serums and Vaccines, and the Bridging Bharat initiative. The Science Integra team has conducted more than 100 webinars in the lockdown period, which is a phenomenal amount of educational activities, and a big salute to them. Thank you so much for associating with us here at Amox. I usually like to start by placing on record my gratitude to our president, Dr. Nandita Palshetkar, secretary, Dr. Arun Nayak, both of whom have always supported all of our educational activities, everything that we do. And I just have to pick up the phone and talk to them, and they'll say, okay, maybe I can't be there personally, but you please go ahead and do the right thing. Make sure that you disseminate knowledge in this difficult time, which of course serves to continue our education, at the same time prevents us from getting depressed, because we keep seeing all our wonderful friends and the faculty who have joined us. Today we are doing this event in association with three different societies. We have the Amravati Society, the Akula Society, and of course the Yavatmal Society, all of which are part of AMOGS. And I would like to thank all the office bearers from these societies for personally being here in spite of their busy schedules and participating in today's program. We have two very distinguished speakers who are there today. The first is Dr. PK Shah, a past president of Foxy, and the second is Dr. Murlidhar Pai. But to start the ball rolling, I want to introduce our chairpersons for today. Can I have the next slide, please? Our first chairperson is Dr. Sujata Dalvi. She is an office bearer of AMOGS, and she is a managing council member of the Mumbai OB/GYN Society, honorary clinical associate at Navroji Wadia Maternity Hospital, assistant editor of Choki, and the first joint secretary of AMOGS. Madam is on the way and she will join us any minute. Can we have the next slide, please? Our next distinguished faculty is Dr. Vaijanti Pathak, and she's been a past president of the Amravati OB/GYN Society. She's been treasurer of FEMCON 18, which was held at Amravati, chairperson of the Communication Skills Workshop at the State AMOX Conference, which was held in Amravati in a different era when we used to all have physical meetings. I remember that program because I had myself been there for 2 days on that weekend, and it was beautifully conceived and excellently organized in spite of the huge crowd and rush which normally happens at the annual AMOX conference. In her presidential year, she has also received the Foxy Smruti Mylon Save the Girl Child Award, the Foxy President's Rotating Trophy, and the Foxy Dr. D.K. Tank Reproductive Healthcare Promotion Trophy. Welcome, Dr. Vajanti Pathak. Next slide, please. Dr. Varsha Ghate is known to everybody who's been part of Maharashtra obstetrics and gynecology or any educational activities that we conduct in this state. She's a practicing OBGYN since the past 25 years, been a past president of the Akola OBGYN Society and the Women's Wing in IMA Akola. Her areas of interest include high risk obstetrics and infertility. She's conducted workshops for adolescent men, boys and girls at 56 schools, including rural areas, when she was the president of the Women's Wing of IMA Akola. I remember traveling there at a particularly difficult time. It was a long road trip, but she was so sweet and kind. It was impossible to refuse Akola Society's invitation. And we did a nice meeting there, which was a physical meeting. I don't know if she remembers, because I think there's a long train of people who want to visit Akola Society, and they regularly keep having clinical meetings in that era, like I said, when we used to have physical programs. Welcome, ma'am. Next slide, please. Dr. Nilima Ardak Thakre is the president currently of the Amravati Society. She is the treasurer of the State AMOX conference, which we just referred to. She is the organizing secretary for the zonal conference, which was held in 2016. She was a zonal coordinator of AMOX in 2016-18. And of course, she's received multiple awards during her tenure when she was the president. She's been faculty for several conferences, workshops, health awareness programs, and she's contributed innumerable articles to journals and souvenirs. Her special area of interest is obstetrics and adolescent healthcare. She's been the main person and the driving person behind this entire program. I just had to give her one phone call and everything was executed for me. Normally, I need to micromanage every single small little thing when I do an event, but here she was the perfect coordinator with me, and this entire program would not have been possible without her ideas, her conceptualization, and execution. Thank you so much, Nilima ma'am. Next slide, please. We have amongst us a very distinguished guest, a past president of Foxy, past president of Mumbai Society, and several other organizations. But I will not take any further time, and I would like to hand over to the chairpersons to introduce our very distinguished guest speaker, Dr. PK Shah sir, who is going to speak on RH ISO immunization. Thank you very much.
Thank you, Pratik sir. Am I audible?
Yes, ma'am, please go ahead.
Thank you, Pratik sir, for your kind words. Good afternoon, one and all. First of all, I must thank all the organizers for giving me this opportunity. Really, I am honored to be chairperson for this webinar. For this important webinar, we are privileged to have an eminent faculty, Dr. P.K. Shah sir, to enlighten us for RH ISO immunization. P.K. Shah sir, professor and unit head of the Department of Obstetrics and Gynecology, SET GS Medical College and KEM Hospital, Mumbai. He is past president Foxy 2012-2013. Has been Indian College of Medical Ultrasound, Indian Association.
Unmute. Unmute. Can't hear.
Joint Secretary IMAGES, Hello, Wellstart International USA, Foxy representative to AOFOG 2010-2013, co-editor of Obstetric and Gynec Journal Today. He is a member of Safe Motherhood Committee FIGO 2013 and 18, USG Committee 2013 and 2017, Chairperson of Imaging Science Committee SAFOG 2017 and 2019. RH isolation is an important topic in our day-to-day practice, and these high-risk pregnancy should be managed very, supervised very, and managed very properly. So I request Dr. P.K. Shah sir to start his presentation. Please, sir.
I would request everybody except the chairperson and the speaker to please mute themselves and to keep their video off. Thank you.
Okay, thank you very much, ma'am, for your kind introduction. At the outset, let me thank Dr. Nandita Palchetkar, President MOPS, Dr. Arun Nayak, and the most important person for today's webinar, Dr. Pratik Tambe. I also acknowledge the presence of my dear friend from Manipal, Dr. Muralidhar Pai. And let us begin with the topic, and that is management of rhesus negative pregnancy. I'm going to talk to you on epidemiology, pathology, management problems in our setting, recommendations, and conclusion. Going into the history, we all know 1940 the Rh antigen was discovered by Lensteiner and Weiner, and in 1941 Rh antibody were found out by Levine et al. In India, the incidence is around 4.6% now. China 1%, black population 7.8%, European 15%, and Basque in Spain 30 to 35%. What is this isoimmunization? It's the production of immune antibody in an individual in response to an antigen derived from another individual of the same species, provided the first one lacks that antigen. It occurs in two stages. First stage is a sensitization and second stage is isoimmunization. Luckily, the incidence of isoimmunization is low due to ABO incompatibility, which confers protection against Rh antigen. Critical sensitizing volume is zero point 0.1 milliliter. Inadequate placental transfer of immunoglobulin occurs. There is Rh stimulus non-responders, almost 30% of them, and that is why we have low incidence of Rh isoimmunization. There is a difference in immunogenicity of different antigens. So what is the pathophysiology? What are we talking about? There are two common systems of blood group, and it is classified into ABO system and research system. The ABO system, you all know about A group, B group, AB group, and O antigen. Whereas in research, we have C, capital, small c, capital D, capital E, small e, and G. Now remember, there is no small d. Every time we have been hearing people, they say that capital D, small d, or two small d's, etc. But there is nothing like d antigen, small d antigen. When you write small d, it represents absence of capital D allele, that is the D antigen. Please remember this very clearly. The D antigen is considered to be the most immunogenic, the Rh factor. D antigen is most immunogenic, and you have out of Rh positive 85% homozygous, that is two alleles of capital D 35%, and heterozygous, that means single allele of capital D 50%. Whereas the rest of the 15% are Rh negative. What are the risks of immunization at different times during pregnancy? In first trimester, it is 3%, second trimester, 12%, third trimester, 46%, intrapartum, 50 to 55%, when the feto-maternal hemorrhage is less than 1 milliliter, and that occurs in almost 50%. And if it is more than 30 millimeter, the incidence is just 1%. In spontaneous abortion, the risk of immunization is around 3%, and therapeutic abortion up to 5%. What is the pathophysiology? Try to understand that if the husband or the partner is having one copy of RHD gene and the woman is negative, then they will have 50% of their children Rh positive and 50% Rh negative. Whereas if the husband or the partner has two copies of RHD gene, that means capital D, and the woman does not have copy of Rh gene, then all children will be Rh positive. Now, feto-maternal hemorrhage and Rh incompatibility. The amount of fetal blood necessary to produce Rh incompatibility varies, but as little as 0.1 milliliter of Rh cells have been documented to create incompatibility. Studies have suggested that up to 30% of persons are non-responders with Rh blood. They never develop Rh incompatibility even when challenged with large volumes of Rh positive blood. Now, this is something which you have to keep in mind. Rh alloimmunization occurs by 1 to 2 mechanisms: after incompatible blood transfusion or after feto-maternal hemorrhage between mother and an incompatible fetus. Feto-maternal hemorrhage may occur during pregnancy in almost 10% or during delivery around 90%. Notwithstanding, the fetal RBCs have been detected in the maternal blood in all three trimesters, 7%, 16%, 29%, without apparent predisposing factor. Initial maternal response to Rh sensitization is low, and simply because you have IgM antibodies. These are confined to maternal circulation only, being unable to cross the placental barrier. Within 6 weeks to 6 months, IgG antibodies are formed. These are able to cross the placenta and destroy the fetal Rh positive cells. Therefore, firstborn infants with Rh positive blood type are not affected It is a short period of first exposure of mother to fetal RBCs is insufficient for production of significant IgG antibody response in the fetus. Now, what happens when the baby is affected? Hemolytic disease of newborn, the sequence of in utero events that maternal IgG enters fetal circulation through placenta, destruction of fetal RBCs occurs that causes fetal anemia when the hematocrit is less than 30%. Heme is formed in excess because of destruction of RBCs and it is converted into bilirubin, so the fetus has fetal hyperbilirubinemia. Both are neurotoxic, but the effect is cleared by placenta and metabolized by the mother. Extramedullary erythropoiesis is stimulated and immature erythroblasts are produced. When cell destruction exceeds production, the fetus will get anemia. More demand in extramedullary sites to produce more and more RBCs that will cause hepatosplenomegaly. Heart failure eventually results with ascites, edema, and pericardial effusion, what we call as erythroblastosis fetalis. And if you have hydrops fetalis, it occurs when the hematocrit is below 15%, often results in fetal death shortly before or after the birth. And the affection rate in newborn from male to female fetuses is 13 to 1. This is how the affection occurs. I have already talked to you about this. What can happen to a mother? The mother can have increased blood pressure if she has got hydrops fetalis when the baby is affected. She can have mild edema, albuminuria, polyhydramnios, postpartum hemorrhage, and DIC. What is the risk of RH sensitization? The risk and severity of sensitization response increases with each subsequent pregnancy involving an ABO compatible fetus with RH positive blood. Without prophylaxis, this risk is 16% after 2 deliveries. 1.5 to 2% occur antepartum, 7% within 6 months of delivery, and 7% manifest early in second pregnancy. And that is how you have about 16% mothers involved and have sensitization. With prophylaxis, the risk drops to 0.1 to 0.2%. Aforementioned risk depends on three main factors: the volume of transplacental hemorrhage, extent of maternal immune response, and concurrent presence of ABO incompatibility. Because it's protective, the risk drops to almost 1.5 to 2%. RH incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future. How do you manage? The history of potentially sensitizing events should be kept in mind, and you should take proper history, like whether she had any abortion, either spontaneous or induced, whether she had any invasive procedure like amniocentesis, chorionebular sampling, chordocentesis, etc., abdominal or pelvic trauma, antepartum hemorrhage, especially abruption, intrauterine fetal demise, multiple pregnancy, manual removal of placenta, ectopic pregnancy, cesarean delivery, etc. Other aspects of management includes the history to be explored, and that includes prior blood transfusion, RH blood type of patient and the spouse, very important, all previous pregnancy outcomes and interventions, if any, to be kept in mind. If there is a history of hydrops in previous pregnancy, there is 90% chance that it will recur in the next pregnancy. Whether there was any previous administration of RH IgG, mechanism of injury in cases of maternal trauma during pregnancy, and presence of vaginal bleeding and prior invasive procedures. The objective of antenatal management includes two things. Number one is the prevention of RH and immunization of RH negative unsensitized women, and early detection and treatment of anemia in sensitized women. Sensitization is determined via indirect Coombs test, otherwise called as antibody screen. Now I'll go through this busy slide. Be patient. If you have a mother who is RH negative, maternal antibody screen should be done at 20 weeks, 24 weeks, and 28 weeks. If the screen is negative, you can administer, hello? You can you hear me? Hello?
Yes, sir, we can hear you. Please
Yeah,
go ahead.
okay. You can administer 300 microgram of immunoglobulin at 28 weeks. At delivery of the baby, the RH status of the newborn should be checked. If baby is RH negative, no further treatment is required. But if the baby is RH positive, again give her within 72 hours of delivery 300 microgram of NTD. If she is positive after doing the antibody screen, when the mother is RH negative and the father is RH positive, if the screen is positive, manage as RH sensitized pregnancy, either do amniocentesis for estimation of fetal bilirubin levels or optical density at 450 nanometer. Further management is based on fetal condition and the determined by percutaneous umbilical blood amniotic fluid analysis, ultrasound examination, and Doppler ultrasound of middle cerebral artery. What is this? If antibody screen is negative, the ICT, indirect Coombs test, is negative. It is repeated as I have already told you at 20, 24, and 28 weeks. Give at 28 weeks prophylaxis. What is we call nowadays is routine antenatal NTD prophylaxis, RAADP. At 28 weeks, give intramuscular injection of NTD immunoglobulin in deltoid, not in gluteal region, where it may go into the fat instead of muscles. It is polyclonal derived from human plasma. We do not use monoclonal nowadays, and there is an intravenous preparation which is available. It is used only for large feto-maternal hemorrhage. The name is Windrow SDF. What are the American College of Obstetrics and Gynecology guidelines? That RH negative woman non-immunized at 28 weeks 300 microgram, abortion less than 1250 microgram, though they say that you can give 300 microgram, and abortion more than 12 weeks 300 microgram. Any pregnancy event which warrants use of NTD, give 300 microgram. Postpartum within 72 hours 300 microgram if baby is RH positive. Delivery less than 3 weeks after the administration of RH immunoglobulin, repeat dose is unnecessary unless there is large feto-maternal hemorrhage occurs. NTD following molar pregnancy if it is a partial mole and not complete mole. What are the risks of NTD immunoglobulin? That you can have a risk of anemia, enhancement of maternal primary immune response to D positive RBCs, adverse obstetric outcome, reduced maternal response to postpartum rubella immunization, short or long-term harm to the fetal immune system, and there is no evidence that maternal administration of NTD immunoglobulin results in any significant risk. Management of large fetal-maternal bleed, do a rosette test, maternal blood plus NTD plus indicator RBCs with RHAG. If rosette is formed, measure percentage of fetal cells by Theo or Betke test or flow cytometry. The fetal blood volume is equal to maternal blood volume multiplied by maternal hematocrit multiplied by percentage of fetal cells. And keep in mind that additional NTD is required depending on the amount of RBCs in the smear. And if you have 0.5 milliliter RBCs, you can give 10 microgram, 20 microgram if it is 1 milliliter, 100 microgram if it is 5 milliliter, etc. Screen positive women should not receive NTD. Please remember this very clearly. Once she has indirect Coombs test positive at 28 weeks, do not give NTD. It is not effective once immunization to do antigen has occurred, and even will not prevent a rise in maternal titer. What are the precautions during delivery? Ensure consultation that with neonatologist, that the neonatologist is present at the time of delivery. Don't give oxytocin at delivery of anterior shoulder, especially methergine is not to be given unless she has PPH, which can be given later on but not prophylactically. If manual removal of placenta is required, do it gently. If blood transfusion is indicated, use RH negative blood compatible with mother's blood. Early clamping of umbilical cord is indicated close to maternal side, and leave a long length of cord about 15 to 20 centimeters in case the baby requires transfusion later on. Management, again, the neonatologist is very important. Send cord blood for ABO, RH typing, direct Coombs test, hematocrit, hemoglobin, bilirubin level, peripheral smear, etc. If fetus is RH negative, no further intervention. If positive, determine the dose of RH IgG immunoglobulin to be administered by a 4-step lab procedure. What is this 4-step lab procedure? Is a rosette fetal RBC screen for fetal or maternal hemorrhage. Acid illusion, that is clear Bedke test to quantify, means to find out amount of RBCs in maternal circulation and estimate the volume of fetal-maternal hemorrhage. Calculate the dose of RH IgG to be given within 72 hours of delivery. There are papers that say that whenever you remember, you can give NTD after delivery, if not within 72 hours. And there are papers that says you can give up to even 28 days. This is a rosette test. Negative is on the left side, positive with the clumps which are there, like rose. You can see it on a positive rosette test. And once it is positive, you can go for clear Bedke test, which will tell you the number of fetal RBCs in total amount of maternal RBCs. For sensitized women, management is guided by following: presence or absence of history of affected fetus in previous pregnancy with severe anemia or hydrops. What is the maternal antibody titer? And sensitization may be determined by doing antibody screen using indirect Coombs test. That is a direct Coombs test. When the baby is born, we collect the blood and we do it directly on that. Whereas in indirect, it is a maternal serum through which we add the RBCs of a donor, and then the same procedure of finding out the Coombs test, that is indirect Coombs test. Now, how do you manage a sensitized RH negative woman? Please don't try to read this slide. If there is no previous history of affected fetus, obtain the ABO and RH group of husband. Very important. If positive, obtain antibody titer. If the antibody titer, if the husband's blood group is negative, no further testing is required. If the husband's blood group is positive and if the antibody titer is below critical level by 36 week of gestation, continue pregnancy to term, but do not allow to go into post-datism. If antibody titer beyond critical level, that is 1 in 16, after 34th week, deliver immediately. If antibody titer is beyond critical level before 34th week of gestation, then you need further testing, like what is the peak systolic velocity of middle cerebral artery using Doppler, then amniocentesis for analysis, and spectrophotometry and ultrasound examination of the fetus to see whether she has undergone fetal hydrops changes or not. And then you can have a postcutaneous umbilical cord blood sampling percutaneous chordocentesis for hematocrit and hemoglobin level. Now, if she's mother is sensitized and there is a previous history of affected fetus, establish the sensitivity, do chordocentesis, see what is the hemoglobin and HCT, etc. You can do amniocentesis or you can go for middle cerebral artery Doppler regularly. How do you assess the fetus? Hemolysis invasive procedures that includes amniocentesis and checking the optical density at 450 nanometer to check the level of bilirubin in amniotic fluid. Or you can directly do the fetal blood sampling and hemoglobin of the fetus and hematocrit. Now coming to middle cerebral artery, Doppler, accurate and non-invasive screening tool for detecting moderate to severe fetal anemia. The sensitivity is 100% and a false positive rate of anemia is 12%. Its use has resulted in up to 80% reduction of invasive testing like amniocentesis or chordocentesis. It is not useful before 18th week of gestation, the middle cerebral artery Doppler. The reticuloendothelium system is too immature to hemolyze enough cells that can cause significant anemia before 18th week of gestation. This is not a reliable predictor of severe anemia after 35th week. So please remember, MCA can be used to guide the management of these fetuses between 18 to 35th week of gestation. It is found to be similar or better than amniocentesis and the optical density at 450 nanometer in prediction of anemia. And we all know about how to take the middle cerebral artery Doppler. There is a very high peak systolic velocity in these cases because of increased cardiac output and the viscosity of the blood is reduced. How do you find out which is abnormal when you are doing the middle cerebral artery peak systolic velocity? So if the period of gestation is 24 weeks, it should be within 48, that is double. If it is more than that, you know that the peak systolic velocity is more. Same way you can calculate 30 weeks should be less than 60. If it is more than 60, it is a cutoff. Now, how do you interpret the results of middle cerebral artery Doppler velocimetry? In unaffected, mildly affected fetus, you will find normal middle cerebral artery Doppler, and the Doppler is repeated monthly and deliver at or near term after lung maturity. There is low risk of intrauterine fetal death. Never allow the pregnancy to go to post-term or post-dated. Moderately affected, middle cerebral artery Doppler will show you about 1.5 multiples of median, the MOM, repeat after 1 to 2 weeks, deliver after lung maturity, and enhancement of lung maturity may be necessary in these cases. If the baby is severely affected and the middle cerebral artery Doppler shows you 1.55 MOM or has frank evidence of fetal hydrops, fetus needs help to attain lung maturity before delivery, and it's a high risk of intrauterine fetal death. We all know about Liley's and Queenan's charts that we used to use once upon a time. We do not use it anymore nowadays. So when you have a RH sensitized pregnancy, the MCA Doppler velocimetry, you do peak systolic velocity. If it is 1.5 MOM and fetal blood sampling, then you can do amniocentesis. If middle cerebral artery PSV is less than 1.5 multiples of medium, then monitor the MCA 1 to 2 weekly. When do you give intrauterine blood transfusion? Recommended treatment for severe or hemolytic anemia in utero, typically carried out between 18 to 35 weeks, may be given intraperitoneal or intravascular, that is into the umbilical vein, even intrahepatic portion of the umbilical vein. ORH negative packed cell with hematocrit of more than 80% is used. Amount to be transfused in milliliter is gestational age multiplied by 20, where gestational age is more than 20 weeks. Like say you have 22 weeks, then you can give 220 cc like that. And this is how you give the intravascular intrauterine blood transfusion. Sensitized RH negative woman, the postpartum management of the neonate includes baby, if alive, should be admitted in the NICU. Urgent exchange blood transfusion is indicated in moderate or severely affected neonates, and the neonatologist will take care of all this. And if it is a mild affection, phototherapy is required. Special feto-maternal risk states include abortion, up to 5% chance of sensitization, and you can give 50 microgram is recommended before 12 weeks. And if it is more than 12 weeks, you can give 300 microgram. Invasive fetal procedure can lead to sensitization to up to 11%, and you have to give 300 microgram to prevent it. Antepartum hemorrhage, especially when you have placental abruption, 300 microgram state, and repeat after 12 weeks later if pregnancy lasts longer. If you have done external cephalic version, you can have a chance of 6% sensitization, and you have to give immediately after ECV dose of 300 microgram. Delivery with fetal-maternal hemorrhage. The normal amount of fetal blood that enters the maternal circulation during delivery is only 5.5 milliliter. Dose of RH immunoglobulin given 300 microgram will neutralize nearly 30 milliliter of whole blood or 15 milliliter of Rh positive fetal RBCs. Management is guided by the estimated volume of fetal-maternal hemorrhage determined by four-step lab test, which I just now discussed. Dose of Rh-IgG given after sensitization is at least 20 microgram per milliliter of fetal RBCs. There are recent advances. You can do non-invasive fetal RHD genotyping from fetal cell-free DNA in maternal circulation. Now, this is the best way you can find out whether the husband, by picking up the uh, nuclear material of the fetal cell, you can pick up very easily whether the father is homozygous or heterozygous. Actually, there is nothing like homozygous and heterozygous. It is one D allele, capital D allele, or two capital D allele, whether that is present or not. And then you can decide whether the patient needs further management with NTD or not. Point of care test POCT is a rapid test for determining Rh status, not available. A lower 50 microgram dose preparation of Rh-IgG is used for following first trimester abortions, as we said. And the concept of partial D and weak D antigens usually test positive but can also form anti-Rh antibodies. Last few slides. What are the take-home points? That every woman of childbearing age should have blood group ABO and Rh types done at first contact. Obtain ABO Rh types of husband of woman found to be Rh negative. This can be done by, just now I told you, fetal cell free in the maternal blood. Ensure ICT is done at 20, 24, 28 weeks of pregnancy with appropriate prophylaxis. Single postpartum dose may be inadequate in case of fetal-maternal hemorrhage. What are the problems in country like ours? You have a very high cost of immunoglobulin. And even if the patient is being treated by you, if she cannot afford, she will not take it. There is a lack of resources to adequately investigate and monitor fetus in utero. In smaller places, in villages and all, you don't have these facilities. The NTD is not available at times. And if it is available, it is very costly. Low turnout for antenatal clinics. We all know that we do not have 100%. All pregnancies are registered with doctors, and hence we miss out on all some of these cases who are Rh negative. There is a poor documentation of prior sensitizing events. Some are yet to fully grasp the import, and there is a loss of case notes. What are recommendations? Advocacy for partnership with Government of India and NGOs to help subsidize the cost of immunoglobulins. Luckily, in teaching institutions like where I worked in KEM and SCIEN, we used to have at a low cost Rh NTD available with the help of the NGOs. Special insurance cover for Rh negative women ensures ease of procurement when needed. Involvement of clergy as part of premarital counseling. Creation of special fora or groups for Rh negative people where potential Rh negative spouses can meet. Now this is very important, that just like we have in breastfeeding, we have a group of mothers who breastfeed, and they have a group. You can have in all these Rh negative mothers, they can form a group and help each other. To conclude my talk, ladies and gentlemen, rhesus immunization is a real problem. Real efforts need to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolysis disease of the newborn remains. When I did my first course way back in late 70s and 77, 78, 79, what number of cases we used to see of Rh isoimmunized pregnancies. Now we hardly see these patients. That's a good thing. Great advancements have been made in the detection and management of this condition, and many more of our Rh negative women can now have happy obstetric careers. Thank you very much, ladies and gentlemen, for patient hearing, and thank you very much, the organizers, for giving me this opportunity.
Thank you, sir. That was a fantastic talk. And I would like to welcome Dr. Sujata Dalvi, our first Joint Secretary of AMOGS. Madam has joined us. Welcome, Madam, and thank you for joining in for today's program. We would request the chairpersons to give their closing remarks. I don't think there are any questions so far, sir. We'll have to wait till the second speaker has finished, and then maybe if there are any relevant questions, we'll take them. Any closing remarks from the chairpersons, please? Then we can go to the next speaker, Dr. Murlidhar Pai. Can we have his introduction, please? And I would request the chairpersons to please introduce sir.
Am I audible?
Yes.
Yeah. It gives me great pleasure to introduce to you Dr. Murlidhar Pai. He was the best outgoing MD candidate in 1989 and a topper in DGO in June 1988 from KMC Manipal. He has been awarded the Best Teacher Award for 8 times and 3 times for the Best Teaching Material at KMC Manipal. He was the author of Holland and Brew's Manual Obstetrics, 4th edition Obstetrics and Gynecology, and a corresponding national editor and jury for the Best Article Award Journal of OBGY of India 2011 to 2014. He was the national chairman Foxy Public Awareness Committee in 2004. He has received 3 Foxy National Awards, Porion Senior, Junior for the Best Research and Imaging Science. He has done fellowships in infertility and laparoscopic surgery at USA, UK, Germany, Belgium and Malaysia. To his name, he has won 72 publications, 443 publications, guest lectures, and he has won several Best Article and Paper awards. He is the founder of Medical Superintendent of Central Referral Hospital, Sikkim in 1997 and the Deputy Director Planning MAHE Manipal 1997 to 2000 and in charge of the Academics and Faculty Development Manipal, Mangalore, Sikkim, Nepal and Malaysia campuses. He has a 34 years of teaching experience and a 30 years of experience as MBBS, MS, DNB, OBGY, MCH, FNB, Reproductive Medicine and Surgery Examiner at national and international universities and NB. With this brief introduction, I request Dr. Murlidhar Pai to begin his lecture.
Thank you very much. And I thank AMOGS as well as Dr. Nandita Palshetkar, Dr. Arun Naik, and Dr. Pratik Tambe for inviting me to give this lecture. And my greetings to Dr. P.K. Shah, sir, who have been guiding me last 34 years. As somebody said, there are 3 PKs in our lives. One is P.K. Shah and Pratap Kumar Narayanan, okay, and P.K. Sekran. So I will share my slides now.
So requesting everyone else to please mute themselves and the chairpersons can keep their video on. We'll keep our videos off.
Okay. So you can see my first slide. Yeah. You can see my slides, sir?
Yes, sir. Please go ahead, sir.
And you can hear me. Okay.
All right, sir.
Thank you very much once again. So today I have been asked to talk on hypertensive disorders of pregnancy, when and how to intervene. Well, all of us know any problem that has caused because of pregnancy, the definitive management is delivery. So there is no climax, there is no secret, there is no suspense here. The question is when to deliver. Like any other situation, when to deliver becomes suddenly a $1 million question, especially in hypertensive disorders of pregnancy. We have to walk a tightrope in almost all situations in obstetrics, especially in hypertensive disorders of pregnancy. We have to balance between the maternal and the fetal health. If you are trying to give best care to the mother, the baby may suffer. That means if you aggressively bring down the blood pressure, the baby may have FGR, it can suddenly die as well. And if you deliver them too early for the mother's sake, they may not die inside the uterus, they may have an early neonatal death. Now, if you err on the side of fetus and try to extend the pregnancy beyond a certain limit, then the mother will be at risk of developing all complications of hypertensive disorder. Traditionally, the talk has to start with the classification because it has a bearing on the management. So I'll quickly dedicate one slide for the classification of hypertensive disorders of pregnancy. When it is 140 by 90 millimeters of mercury after 20 weeks on two occasions spread by 6 hours apart, it's called gestational hypertension. Along with that, if there is proteinuria of more than 300 milligrams per liter, plus or minus edema, it becomes preeclampsia. To this, if there is convulsions, then it will become eclampsia. Now, all of them can be in the backdrop of chronic hypertension. So, it can be chronic hypertension superimposed by either preeclampsia or eclampsia. As I said earlier, when to deliver? It is pretty much clear as far as hypertensive disorders of pregnancy is concerned. When the disease becomes severe or if the features of severe disease appear, it's time to deliver. All of us know traditionally we talk about this as imminent eclampsia. I'm going to detail them in next few slides. Let us look at the other indications to deliver before term. That is the meaning of this. In other words, irrespective of gestational age. HELP syndrome. There may not be a full-blown picture of preeclampsia, especially there may not be sometimes hypertension, what we call atypical preeclampsia. There may be just a HELP syndrome where there is hemolysis, elevated liver enzymes, and low platelet with or without hypertension. Hepatorenal failure alone can also be an indication to deliver irrespective of gestational age. Severe fetal growth restriction, even though now the recent task force has downgraded the value of FGR in determining the severity of preeclampsia. However, if there is severe FGR, independent or along with preeclampsia, it's an indication to deliver. Abruption. All of us agree that there are two things in obstetrics that cannot be prevented. Number one is preeclampsia itself, and number two is abruption. So abruption is something which you anticipate in preeclampsia, but you cannot really exactly pinpoint when exactly the lady is going to have abruption. So as soon as abruption takes place, if the baby is alive, we have to deliver the baby in order to save that baby. There's no question of conservative line of management for abruption in preeclampsia. The only thing that you can prevent is eclampsia. Of course, if there are no other complications, then you can deliver them after completion of 37 weeks. Unlike in diabetes complicating pregnancy, we do not want to wait till 39 weeks because the chance of RDS is not so high when compared to GDM. That's exactly why once the mother completes 37 weeks, there is nothing much to gain. Rather, you may lose. There may be a slightly exaggerated lung maturity due to the stress in preeclampsia. So once the mother achieves 37 weeks, you can deliver. Now let me come to the promised features of severe preeclampsia or what we call imminent eclampsia. Traditionally, for undergraduates, we say the features means it consists of symptoms, signs, and lab findings. All of us know these symptoms: headache, which is due to either edema or due to hemorrhage in the cerebrum. The new onset cerebral or visual disturbance, what we call blurring of vision. And there can be papilledema in the fundus. Epigastric pain, again, is a sign of hemorrhage in the subcapsular aspect of the liver, which is a feature of severe preeclampsia. oliguria due to vasospasm and decreased renal perfusion, there can be oliguria. Along with that, a sign of persistent blood pressure of more than or equal to 160 by 110 millimeters of mercury. Serum creatinine, now I come to the lab values. Serum creatinine more than 1.1 milligram per dl or simply doubled. AST, ALT, these are the liver enzymes which are doubled in severe preeclampsia. Platelets, anything less than 150,000 is low, but when it goes below 100,000, it is a feature of severe disease. Pulmonary edema, already she is in a complicated state. One need not wait for all of them to appear. Actually, any one of them is good enough to intervene. Earlier, we used to say about severe edema or sudden edema, as well as proteinuria more than 3 grams, or some books even mentioned 5 grams, but that has been downgraded by the task force. Fetal indications to deliver. I have made a small gimmick here. I'm just trying to popularize my own name. Murli's rule of 5. What do I mean by this? If there is severe FGR as suggested by AC less than 5th percentile, poor biophysical profile number or the total score less than 5, low AFI, the amniotic fluid index less than 5, which is called low Likert, and Doppler abnormalities in any one of the 5 vessels. That could be uterine artery, but usually uterine artery is done in the early part, mostly helpful in prediction. Umbilical artery, middle cerebral artery, aortic isthmus, which is coming up in a big way, and ductus venosus. Now, in these vessels, if you see any absent end-diastolic flow or a reversal flow, or simply if you take a ratio of umbilical artery to middle cerebral artery, and if the ratio is less than 1, it suggests that there is a compromise in the fetus. In other words, if there is maternal or fetal compromise, it is time to intervene and time to deliver. Till that time, we have to somehow manage. Why deliver? Because it's been proven beyond doubt that delivery minimizes the risk of complications such as cerebral hemorrhage, hepatic rupture. In fact, Sibai is the authority on preeclampsia. He has published an article or a case report wherein a patient came to ER with severe epigastric pain and they missed severe preeclampsia. That patient had a hepatic rupture and she had a very complicated situation. She didn't in fact survive. So hepatic rupture is one dreaded complication. When a patient with preeclampsia comes with epigastric pain, don't simply give her antacids or injections, pan injections. So you have to suspect hepatic rupture. Renal failure, that is another dreaded complication. Patients may require ICU admission and dialysis. In fact, one of our patients is right now going through several dialysis. Pulmonary edema can be very distressing and can be fatal. Seizure, this is the commonest complication that we see in a case of preeclampsia, which can be due to hemorrhage as well as edema. Bleeding related to thrombocytopenia, whenever abruption occurs, there is consumptive coagulopathy and abruptia placenta itself. In fact, recently we are still having a patient who had most of these complications referred to us from somewhere, and the good news is she is recovering slowly. When to deliver, I have already told you. Now, what I am telling in this particular slide is that if you have to deliver before 32 weeks, that is 31/6/7, then you need to give both steroids as well as magnesium sulfate. Now here, the magnesium sulfate is not for prevention of eclampsia or not only to prevent the eclampsia, it is given for neuroprotection. So before 32 weeks, most of the guidelines will agree that you need to give additional neuroprophylaxis. In fact, it is the management of severe preeclampsia which taught us that the magnesium sulfate used will do double action. Number one, it prevents eclampsia in the mother. It will also enhance the neuronal maturity. So that's why it plays the double role. If the delivery has to occur between 32 and 33 weeks 6 by 7, then there is no need of magnesium sulfate for neuroprotection. However, if you feel that she has got all chance of eclampsia, you can still give magnesium sulfate. In this particular slide, I'm only talking from the point of fetus. Steroids alone should be good enough if not given earlier. After 34 weeks, actually, there is no need to give steroids. As I told you earlier, in cases of preeclampsia, there is an enhanced lung maturity in the fetus because of the stress. The steroids are released. However, our neonatologists tell us at least give a rescue course. That means if the steroids were given 2 weeks earlier, and if the delivery is imminent within 2 days or 48 hours, then 2 doses of rescue steroids should be given. But again, I want to highlight, unlike in the past, now we don't decide on termination based on proteinuria. Proteinuria is one of the complications agreed, but the delivery decision is not based on that. Once there is the endothelial damage is there, then proteinuria is bound to happen, but that in no way is reflected on the timing of delivery. In any case, we should not wait beyond 37 completed weeks. I have already highlighted the reasons as well. We need to remember HDP, hypertensive disorder of pregnancy, is not just about hypertension. In fact, I told you, in cases of atypical preeclampsia, you may not have hypertension at all. I insist the students should tell while defining preeclampsia, it's not just 140 by 90 blood pressure and proteinuria. They must tell that it's a multi-organ disease because it involves all the blood vessels in the body. Vasospasm is the most pathognomonic pathology that is seen. It involves all the organs. It's a multi-organ disease. So accordingly, treatment not only includes antihypertensives, but also anticonvulsives and delivery, and of course, a timely delivery. So to put down the principles of management of preeclampsia are control of hypertension by using antihypertensives, prevention of eclampsia by using magnesium sulfate, and early delivery irrespective of gestation. So let us look at the antihypertensive part, the first part. Whenever we talk about antihypertensives, we need to have a target. This perfect target, hitting the bull's eye, is the target for physicians, not for obstetricians. Our targets are slightly different. We do not want a perfect lowering of the BP, because if you lower the BP too much, then the baby will suffer. So our targets, systolic should be somewhere between 130 to 150 and diastolic between 80 and 100. We should not go below that. How rapidly we should bring down the blood pressure? It is controversial. However, cerebral or myocardial ischemia or infarction can be induced by aggressive and fast bringing down of the blood pressure. So it has to be brought down very slowly like that, 25% over 2 hours. If you suddenly bring down, the maternal ischemia can occur and infarctions can occur, and there can be sudden intrauterine IUDs as well. So it is also advised to look at preeclampsia with a syndromic approach. What do you mean by that? Hypertension in association with thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, and new onset of cerebral disturbances. An obstetrician has to keep all these things in mind while treating a case of preeclampsia. Should not look at only hypertension. What are the principles? The principles in any medication is when to start a particular drug. Here, the question is when to start antihypertensives, because it is very, very clear when to start anticonvulsives. If there is any sign of imminent eclampsia, start anticonvulsives. But the biggest controversy is in when to start the antihypertensives. Of course, it depends upon the level of hypertension. How to treat, in other words, which antihypertensives to use. There are a whole lot of antihypertensives that we know. It all depends upon what to use and what to avoid. As far as which level, the levels are arbitrarily divided into severe, that is 160 by 110, moderate, anywhere between 150 to 159 on the systolic, 100 to 109 on the diastolic. And as far as mild is concerned, 140 to 150 on the systolic side and 90 to 99 on the diastolic side. If there are too many numbers to be remembered, just remember the diastolic values 110, 100 and 90. Now, if that is also too much, just remember two values, that is 110 and 100. Let me tell you why is that. Whenever it is severe, there is absolutely no doubt on anybody's mind that antihypertensives are always recommended because it is believed to reduce the maternal stroke and eclampsia. Whereas the controversy is mostly in mild to moderate cases, mild being 90, moderate being 100. The traditional concern has been aggressive lowering or medication themselves will inhibit the fetal growth. That means if you bring down the blood pressure below 90, though it is the diagnostic point, then the baby would suffer. Little bit of hypertension is good for the baby because it will ensure that there is good perfusion into the uterus. After all, we have blood pressure to make sure that the blood reaches even our great toe, and the diastolic blood pressure makes sure that the blood perfusion occurs even at the level of great toe. All said and done, the exposure to harmful effects of the drugs was another concern. Because of that, in the past, we never started antihypertensives till the diastolic blood pressure was 100. That's why I told you, remember 110 and 100. 100 being the starting point of the antihypertensives and 110 being the starting point of conducting delivery or contemplating delivery. Now let us look at the recent trials. The recent trials have shown us that the prudent approach is better, which also considers the patient's comorbidities and symptoms instead of just looking at the diastolic blood pressure. The diastolic blood pressure may be below 100, that is, let's say 95. But if the patient also has headache, visual disturbances, it is better and prudent to start antihypertensives because there have been cases who have thrown fits even at 90 diastolic. That's why one should not be very rigid in saying, I will not start antihypertensives at 90, I will wait till 100. That approach is not at all good approach. The benefits and potential risks, however, are less clear. I was telling you about the recent trial. The trial targeted whether to start at 90 or whether to start at 100. The CHIPS trial went 5 millimeters below. This is the famous trial that results came in 2015. They grouped the patients into 85 diastolic and 100 diastolic as a starting point for antihypertensives. And another meta-analysis and Cochrane database in 2014 and 2017, both of them told that maternal treatment did not increase the risk of FGR or it did not cause excess fetal risk. That means you can start antihypertensives depending upon the other comorbidities even at 90. In fact, CHIPS trial started at 85 also. So they also found out that lower BP was associated with a reduced occurrence of severe maternal hypertension during pregnancy. These are some of the benefits, but not totally clear. That's why a question mark comes there. But did not result in less preeclampsia or maternal stroke. They reduced the hypertension, but it did not really prevent the maternal stroke. So again, it suggests that more trials are needed. Overall safety, all hypertensive drugs cross the placenta. This is what we need to know. And there are no data for large, well-designed randomized trials on which to base a strong recommendation for use of one drug over another. Having said that, it is very, very clear that avoid ACE inhibitors, ARBs, and direct renin inhibitors because they are associated with renal anomalies and FGR. So they are out. These are the main drugs that physicians use, whereas in obstetrics we cannot use them. Also avoid mineralocorticoid receptor antagonists like spironolactone because they cross placenta and never been proven safe in pregnancy. They are also out. What about thiazide diuretics? Generally not used antenatally in preeclampsia unless the patient has pulmonary edema. It is used sometimes if there is persistence of preeclampsia or hypertension even after the delivery, because now there is no fear of the baby getting problematic. So you can use diuretics to bring down the blood pressure after delivery. Nitroprusside. Now, there is limited clinical experience in this particular drug, possibly because it has got a cyanide poisoning type of effect on the fetus. However, in cases required, 0.5 to 10 microgram per kg per minute is used, but there are so many conditions for their use. What are the conditions? As the last resort, for urgent control of refractory or severe hypertension, and its use should be limited to a short period of time and in an emergency situation. See, there are so many conditions before you use nitroprusside. I have no experience of using this to bring down the blood pressure. Then what to use? Don't use this, don't use that. Then what to use? Of course, in emergencies, now we prefer labetalol. That has emerged the first line of drug. You can see I have changed the color into red to indicate emergency. You start with 10 to 20 milligrams IV stat. Wait for some time. In 30 minutes, if the BP doesn't come down, you can double the dosage, 20, and then go on to 80. But the maximum per day dosage is 300 milligrams only. Usually, we need not reach that particular dose. That's our experience. Or you can give it as an infusion. After giving the initial 10 to 20 milligrams IV stat, you can make an infusion pump 1 to 2 milligrams per minute. There are very few side effects. That's why it has emerged as the first line drug. However, one must know that they are contraindicated in asthma and heart disease complicating pregnancy. The other drug that is used in emergency, when I was in Malaysia, I used to use this hydralazine, 5 milligrams IV or IM stat, or 5 to 10 milligrams every 10 minutes thereafter. Or you can give this as an infusion as well, 0.5 to 10 milligrams per hour. Side effects are headache. This will confuse us with the headache that is due to imminent eclampsia, fetal distress, and severe hypotension that it can cause. It is not at all popular in Manipur. We don't use this that much, but while we were in Malaysia, the government hospitals in Malaysia used to use this, so I have used it there. We would rather choose this one if you don't have the facility for infusion of labetalol. Nifedipine is equally good for an emergency, 10 to 20 milligrams of oral. Now here purposely I have changed the color and made it a bold font, oral, because when I was a UG and PG, we used to give sublingual, and later there have been lots of mishaps in the world. So now it is very clear that we should not use them sublingual. Repeat in 30 minutes, 10 to 20 milligrams every 2 to 6 hours. Again, this also has got headache and tachycardia. As I am underlining one more time, it should be given oral and not sublingual. Now I come to the maintenance therapy after emergency, for maintenance or before emergency to bring down the blood pressure. Labetalol is again the first choice nowadays because it can act immediately. 200 to 2400 milligrams per day in divided doses can be given. Nifedipine also can be used somewhere between 30 to 120 milligrams per day in divided doses. Usually, we have not reached up to 120 milligrams in nifedipine. We have never reached 2400 milligrams in labetalol. Maximum we have used sometimes 100 milligrams 4 times a day or 200 milligrams 3 times a day. That's all we have reached. Methyl dopa used to be a very, very popular drug. It has served us for years and decades, but now it is not available that freely, number one. Number two, we have better drug that is labetalol and nifedipine. If you use methyl dopa, it is 500 milligrams QID. That is, the maximum is 2000 milligrams. The problem with methyl dopa is postural hypertension, and it starts acting very slowly after 24 to 48 hours. So if you want to bring down the blood pressure immediately, nifedipine or labetalol are better choices. Labetalol has both alpha and beta adrenergic blocking activity. It may preserve uteroplasmal blood flow to a great extent. That's the advantage it has. And it has got a more rapid onset of action than methyl dopa, that is within 2 to 2 hours versus 3 to 6 hours in case of methyl dopa. Labetalol has hepatotoxicity, however, and may confuse with HELP syndrome. So one has to be careful. Slightly more adverse outcomes are seen sometimes, especially RDS in fetus, sepsis, and seizures when treatment was for chronic hypertension. Although less well studied in pregnant women, Pinodolol and long-acting form of metoprolol are not used nowadays that commonly. Hydralazine, as I said, it's a hypertensive response, is less predictable. That's why erratic, and we don't use that. It can also be taken orally. However, it causes reflex tachycardia and fluid retention, which limits its usefulness in pregnancy. Nifedipine is safe. Immediate release oral nifedipine for acute severe hypertension, sustained release or long-acting nifedipine for maintenance, and there is sparse data about amlodipine, but edema is one of the big things about amlodipine. It will confuse us. Verapamil and diltiazem also not very commonly used by obstetricians. Methyl dopa, as I said, it was widely used, long-term safety well established, only mild hypertensive agent. It has slow onset of action, and many will not achieve targets or bothered by sedative effect of this. The better outcome than labetalol. Clonidine is the counterpart of methyl dopa. I can say in the postnatal period we prefer to use clonidine because it has got less side effects than the methyl dopa, especially depression in the mothers, possibly of rebound hypertension if it is used, if it is suddenly stopped. So it should be stopped very slowly. Most postnatally when methyl dopa avoided to reduce the postnatal use. Nitroglycerin, an option in pulmonary edema in the rare occasion when IV diuretics are not effective. I told you about this. There are so many conditions before you use this. Given as IV infusion, 5 microgram per minute, gradually increased every 3 to 5 minutes to a maximum of 100 micrograms per minute. What about bed rest? It may improve uteroplasmal blood flow in preeclampsia and prevent exacerbation of hypertension. However, there is no evidence that it significantly improves major maternal or fetal outcomes. If at all, you have to give a left lateral position. It is not recommended in stable chronic hypertensive patients. What about salt restriction? Usually, physicians say to avoid salt in a chronic hypertensive patient, but normal diet without significant salt restriction is generally advised, as salt restriction may induce low intravascular volume, especially in a pregnancy. What about magnesium sulfate as an antihypertensive? Never a substitute for prompt initiation of antihypertensives in severe hypertension, as it has minimal effects on BP. Magnesium sulfate, the main use is as an anticonvulsive. It may also be a neuroprophylactic agent. It may also be used as a tocolytic, but as an antihypertensive, it does not have much use. Antihypertensive medications do not prevent eclampsia. We know that antihypertensives will bring down the BP, and as once mentioned in the earlier slide, it may not prevent eclampsia. It may prevent other complications. So that alone is not enough. I'm underlining it one more time. So anticonvulsives have to be used additionally to antihypertensives, and the drug of choice is magnesium sulfate. And in status epilepticus, you have to add diazepam. And for the long-term use, the neurologist will always prefer phenytoin and Livera. Magnesium sulfate, you can choose whichever regime is popular in your particular center, which charts is 4 grams IV, and then every 4 hours, 5 grams IM on either of the buttocks. 10 grams IM also is the 0-hour dose. Most of us have given it up now because the injections are really painful. Instead of that, most of us go for Zispan regime, which is easy, 4 grams IV, initial dose, and then 1 gram per hour infusion. Therapeutic range is between 4.8 to 8.4 milligrams per dl. Whatever regime you use, you have to monitor the patient for its side effects. Patellar reflexes should be there, and respiration should always be more than 50. These two are actually the effect of magnesium sulfate, direct side effects of magnesium sulfate, but we should also monitor the output. Output may not come down because of magnesium sulfate toxicity, but if the output goes down, then there will be increased toxicity of the magnesium sulfate, and we have to stop magnesium sulfate. Remember, 10 to 15% of women in labor with preeclampsia will develop severe features or abruptio placenta. As I told you earlier, abruptio placenta is something which cannot be predicted or prevented, but you have to take action immediately. That's all. That means whether or not they receive magnesium therapy, irrespective of anything, they can still have abruption. So magnesium sulfate, there are certain contraindications like myasthenia gravis because it's a smooth muscle relaxant. Pulmonary edema also is a contraindication for this, and side effects like flushing, warmth, nausea, headache, muscle weakness, atonic PPH are anticipated. The antidote, of course, is calcium gluconate, 15 to 30 ml of a 10% solution. Repeat convulsions, as I said earlier, give diazepam 10 milligrams but slowly. Whenever you have to give diazepam, you have to give very slowly IV if the patient keeps throwing convulsions while on magnesium sulfate. Thrombocytopenia is a concern in most of the preeclamptic patients, but platelet transfusion should not be used to normalize the count in non-bleeding patients. If you are taking up a section, however, we have to bring it up to 50,000 minimum, then you may use it. Glucocorticoid therapy does not appear to be effective for significantly raising the platelet count in women with preeclampsia. However, after delivery, 2 doses of steroids may improve platelets. Mode of delivery, of course, depends upon urgency to deliver, fetal weight, presence of growth restriction, and presence of CPD, and probability of successful induction with early vaginal delivery. Caesarean section is always preferred in severely growth restricted fetuses, especially if the fetus is also extreme preterm, that is less than 34 weeks and less than 1,500 grams. Fetus is in distress, no question of vaginal delivery, it is better to go for section. I don't have to talk about this. Presence of CPD will automatically ask for section, and the malposition as well. For Bishop's course time, you may end up with section, not at the beginning maybe. In practice, wherever NSU is available with good survival rate, the trend is to cesarean section. What is the anesthesia to be used? Spinal or epidural. Injection pethidine tramadol also can be given during labor. Induction of labor can be given if cervix is unfavorable, either using PGE2 gel or metoprolol. If the cervix is favorable, you can do AR and oxygen. Prolonged induction with a low likelihood of state is best avoided in cancer. Similar management is taken, but if there are complications, you have to give additional treatment. For example, if there is eclampsia, additional supportive therapy is important. If there is disruption, we have to also take care of the DIs, renal failure. If there is help, we have to translate it. We may have to give steroids. If there is pulmonary edema, we have to consider additional diuretic and ventilation support. In addition to what I told, part of management, continuous meter monitoring is very, very important. Arterial or central venous catheter patients with severe cardiac disease, severe renal disease, and severe urea. Avoid excessive fluids. You may have a uh, line ready, but don't unnecessarily give fluid. Most of us will be cutting short the second stage by about 24 steps in order to decrease the stress or strain on the mother. Avoid, of course, nowadays we don't do it at all. However, the 10 units of oxytocin can be given as an active management of blood cells. Postnatally, monitor very closely if features of severe preeclampsia are present. Continue antihypertensives for some time, taper them slowly. Continue magnesium sulfate, sometimes 24 hours to 48 hours is required, but most of us will continue totally 24 hours in the start. Consider diuretics. If the BP is not coming down, it is due to edema, you can consider diuretics. And all these patients should have yearly BP checkup, IP, FPS, and because preeclampsia is a part of lipidemia syndrome. Thank you very much for your patience hearing. Any questions, I'd be happy to answer.
Thank you, Dr. Muralidharan, for giving us very excellent and elaborative talk on when to intervene in a patient of a hypertensive disorders of pregnancy. You nicely elaborated that hypertensive disorder does not mean only hypertension, but it's a syndrome comprising of many other systems basically. So it involves the other systems also. You also nicely gave a Murli rule of 5, which will also tell us when to intervene in a patient of an hypertensive disorders. When you are using antihypertensives, not to bring down the blood pressure to too much of a normal, because then it intervenes into the fetal perfusion. And whenever we are intervening in a patient of a hypertensive disorder, one need not look only at the hypertension, but you need to look at even the comorbidities and then take a decision. So thank you so much for giving us absolute elaborative this thing. I'll wait for any questions, if at all they are there on the chat as such. But there are one or two questions
to add.
Yes.
Ma'am, I want to add one thing regarding Sir's talk. Muralidhar Pai Sir's presentation are so well, and we can visualize and we can perceive the presentations and the screenshots at long term, for long term also. Your presentations are very well.
Thanks.
So, Doctor, one more compliment to you. There are some compliments from the audience, but I'll read it out later. But before that, I would like to say Dr. PK Shah's talk was also equally informative, though the incidence of RH alloimmunization is much less, but we do find patients with RH alloimmunization occasionally, and how important is color Doppler and finding out middle cerebral artery for detection of anemia, and the role of intrauterine infusion in patients who have been detected with RH alloimmunization. There are two questions for Dr. PK Shah. One is, when you are delivering a patient of a RH negative with RH positive husband, can we give oxytocin after the delivery of an anterior shoulder?
It depends whether she really needs or not. It's not that normally during delivery, after the delivery of the shoulder, each and every patient we give either methergine or intravenous oxytocin. But till the time the placenta is inside, any uterotonic that you give can lead to feto-maternal hemorrhage. So try and avoid, unless it is absolutely necessary to save mother's life, any uterotonic agent.
Okay, fine. So that's a message, that any uterotonic agents, until and unless necessary, then only use it. Otherwise, one can avoid using it. Nothing like it. Okay. There's a second
after delivery
question.
Of placenta, you can give if required.
Okay, so they said after the delivery of placenta, if needed, one can use uterotonic, but not before the delivery of placenta. There's one more question: is 50 micrograms of anti-RHD available in the market or no?
It is not available now.
It is not available, yes.
No. So there is no point taking a 300 microgram and taking out only 50 and giving it. Give full dose. It is better anytime, because you don't know exactly how much amount of feto-maternal hemorrhage occurs in first trimester abortions. So
Okay,
why
fine.
waste rest of the NTD injection? Give 300.
Okay. Now there are few questions for Dr. Muralidharan Pai. That methyl dopa is no more available, but it is available in the market as yet. But what is the relation of cardiac disease and labetalol?
See,
If
it
in
is,
case you are
yeah,
using a
because
patient.
labetalol is something to do with the, it is alpha blocker as well. So cardiac disease patients, there can be some problems. So that's why it is relatively contraindicated in cardiac disease patients.
Okay. What is the role of aspirin and calcium? In case you are using magnesium sulfate and nifedipine, can we use both of them together or you can't use it?
See, actually, I didn't touch upon the preventive management as such. I straight away went to the management of severe preeclampsia. That was the mandate. Aspirin, as we all know, is a very useful drug. It won't prevent preeclampsia in toto, but it will definitely bring down the severity of the hypertension and the complications of preeclampsia if started early and in the dosage of 150 milligrams in the night. That's what we do. And as far as magnesium sulfate is concerned, magnesium sulfate and aspirin, of course, we stop aspirin at the gestation of 34 weeks. And whenever we are anticipating delivery, we stop aspirin because
Okay.
it can give rise to some postpartum hemorrhage. There can be multiple effect of that. Like aspirin also will cause postpartum hemorrhage, and magnesium sulfate being a uterine relaxant that can also cause postpartum hemorrhage.
Okay.
So there can be a cumulative effect of all these drugs. So we have to manage, we have to balance everything out.
Yeah, they've asked whether you can use nifedipine and magnesium sulfate. Means you have already started patient on magnesium
Yeah,
sulfate. As an antihypertensive, would you prefer
no,
labetalol or nifedipine? Can you use
yeah,
it?
that's a good question again because again, both the drugs, that is magnesium sulfate as well as nifedipine, have got uterine relaxant action. We would rather prefer labetalol. So in a patient who is on magnesium sulfate drip, either because of neuroprotection or because of prevention of eclampsia, labetalol is a better drug.
Okay. Someone wants to know the dosage of magnesium sulfate as a neuroprotector.
We use the same Zuspan regime, 4 grams stat and 1 gram per hour, at least 24 hours we must give for neuroprophylaxis. It's the same dosage. So that's exactly
Fine.
why we have now switched over to Zuspan because it will double up for both
Both.
neuroprotection as well as for eclampsia.
Right. Thank you so much. There's one more question for Dr. PK Shah. Is antibody testing using optical density of amniotic fluid for RH immunization? Can you do that or no?
No, no, you do
Antibody
bilirubin.
testing for optical
You,
density for RH immunized mothers.
no, no. What we used to do once upon a time in late 70s and early 80s was picking up amount of bilirubin, not antibodies. It was a because you have a heme concentration
Correct.
because of RBC destruction. More and more bilirubin used to be there in the circulation, and that would come into the amniotic fluid. Finding out the level of bilirubin in amniotic fluid, we used to prepare that Liley's chart and used to plot it on that. It is not the antibody; it is the bilirubin that we try and find out the amount. And nowadays, I think people have given up literally because from 18 to 35 weeks of gestation, you can use the middle cerebral artery and peak systolic velocity. So there is no need of it. But if you do not have that facility, we stick back to what we were taught once upon a time about amniocentesis and finding out what is the amount of bilirubin. One more thing I want to say, Sujata,
Haji.
that nifedipine is an off-label use.
Yeah, it is not.
If you see the manufacturer of nifedipine, they have given it in writing to American College of Obstetrics and Gynecology that it cannot be used for prevention of preterm labor, but you can use it only for hypertension. So this is one thing which we have to keep in mind, that the combination of magnesium sulfate and nifedipine is so dangerous that
Yeah,
most of the neonatologists, they tell us that do not use this combination.
yeah,
Right.
I agree
Okay.
with you. That's why I said labetalol is better.
No problem. Thank you so much. There are some complimentary messages from the audience. One,
Really.
Dr. Madhukumar has said nice coverage and turned out to be very informative. And Dr. Sneha Bhuyar, who is a FOXY chairperson for a FOXY breast
Breast
committee,
committee.
she said very good talk. And there was one more message on the chat by Dr. Preeti Sunil Kabra. They have said excellent talk, both our speakers. Okay, so these are the compliments from the audience. So before we start off with the next session, I would like to thank the organizers, especially Dr. Pratik Tambe, chairperson of AMOG's endocrine committee, our president, AMOG's president, Dr. Nandita, and AMOG secretary, Dr. Arun Naik, for giving us the opportunity to chair this session. We would also like to thank Science Integra as providing us with a digital platform, and Bharat Serum Vaccine being an educational partner. This is on myself and on behalf of my co-chairperson. Over to our next session, that is a panel discussion by Dr. Pratik Tambe.
Thank you, ma'am.
Dr. Pratik,
So, yes, sir.
before you start that, I would like to take leave of you because 3:30 I have to
I know
go for my
3:30 you have
teaching
an event, so I
class.
was just getting
No,
worried towards the
yeah.
closing
No,
stages
no,
of
no.
your
It's
talk.
exactly
whether you
3:30.
would-
I'll go for my PG class now. Thank
Yes,
you
yes.
very much.
Thank you so much, sir.
I'll take
Thank you
leave
Okay.
of you all.
for
Yeah.
gracing the
See
occasion.
you,
It was
Murli.
fantastic to hear you.
Thank
Thank,
both the
bye.
speakers. Okay. Yes.
Thank you.
So we have nearly 600 people logged in today, in spite of it being a busy weekday afternoon. So congratulations to all the faculty and everybody working behind the scenes. If there are any closing remarks from the other chairpersons, Dr. Vaijanti, Dr. Nilima, and Dr. Varsha Ghate, I would request you to please speak before we start the panel.
Final words, Dr. P.K. Shah, sir. It was an excellent talk. We have seen you always as a senior most gynecologist guiding us and keeping us motivated. Then Dr. Murlidhar Pai, I have already commented his presentation and his take-home messages help each and every practicing gynecologist, college going and the he's always the best in his giving the take-home messages, and we can follow his guidelines every time. Thank you, both of the speakers. You were excellent, to the point, and in time. Thank you once again.
Thank you, Nilima.
Both presentations are very excellent. No words.
Thank you.
Thank you.
So too many compliments from everybody.
There have been comments regarding your mustache and beard also, sir. People have not seen you so frequently as I do. So everybody is appreciating your
Still talking
physical
person.
appearance.
Yeah,
You're
somebody has
talking
said,
person.
somebody has said PK is looking good, but this is from a male person, so it has come on my cell phone. So PK is looking good. That's what they said.
We'd also like to place on record our gratitude to Dr. Sneha Bhoyer, who's been the past president of Amravati Society, and Dr. Preeti Kabra, she's a past president of Yavatmal Society. Both of them are tuned in for this program. Thank you so much for logging in. Shrimon, can we have the slides for introduction of the panelists, please? It's already 3:30. We should be starting. So at the outset, let me take this opportunity to welcome all our distinguished panelists. This is a simple, straightforward panel. It's on obstetric hemorrhage. It will include both antepartum, postpartum hemorrhage, and some key concepts about how we try and prevent it, that is prophylaxis, as well as treatment of hemorrhage when it does happen. So to start off with, we have Dr. Kiran Gupta. She's the president of Akola OBGYN Society and waiting very patiently right since the beginning of this program. She logged in very early. She's a practicing gynecologist since the past 23 years and director of the Icon Multi-Specialty Hospital in Akola. Welcome, Dr. Kiran Gupta, ma'am. Next slide, please. Dr. Atul Padmavar is the president of Yavatmal OBGYN Society and he's an associate professor at VNGMC in Yavatmal. Good afternoon, sir. I think we can see you very clearly today. Yesterday there were some technical issues, but today I think your audio visuals are just fantastic. Looking forward to hear from you. Next slide, please. Dr. Pooja Khetpal Sevani has a fellowship in infertility and basic endoscopy. She is an assistant professor at Amravati and she's a clinical committee member and co-convener for PG workshops, which was at the MOX conference, the annual conference in 2020. She has had multiple presentations and paper presentations at state and national level. We look forward to hearing from her as well. Welcome, Dr. Pooja. Our next panelist is a very distinguished panelist. She is Dr. Mangal Sharad Rathi. She is practicing since the past 25 years and she is the first sonologist of Paratwada area, which is in Maharashtra. Received the Best Secretary Award from the Maharashtra State IMA in 2019. Also, the Wonder Foxian Award, which was awarded to her last year during Dr. Nandita Palchetkar's tenure when she was Foxy president. And she has, to her credit, numerous events, awards, and presentations to her credit. Next slide, please. Dr. Pooja Bandekar is an associate professor of obstetrics and gynecology at the St. GS Medical College, and she is the head of unit at Vadia Maternity Hospital in Parel, Mumbai. Incidentally, Dr. Pooja and I share the same postgraduate teacher, who is Dr. Kaizad Damania, and we miss her and we wish him well during this difficult pandemic. Obviously, her field of interest is high risk obstetrics, and at one point of time, because there was a lack of good PG teachers, she was actually running two units. I don't know how she physically managed it, but she was head of two different units at Vadia Maternity Hospital, which has a caseload of about 10 to 15,000 deliveries per year. So you can imagine what sort of work she must be doing. Welcome, Dr. Pooja Bandekar. Next slide, please. I don't know if Dr. Jairani has been able to join us, but Dr.
Yes.
Jairani is a very distinguished personality from the South. She is also possesses a diploma in reproductive medicine. She is a very distinguished committee member of OXI, which is the Society of Chennai. Multiple awards and prizes to her credit, including the gold medal in the TGO University examination. Madam had sent a message that she was busy with an emergency, but hopefully she will join us very soon. Next slide, please. Last but not least, we have Dr. Geetendra Sharma, who I like to call the medico-legal expert of Foxy, and he is not only an MD gynecologist, but he's been practicing law and done LLB. He has had 15 gold medals throughout his academic career, author of multiple books regarding the law, and of course, a past president of the Ahmedabad Society. Sir is currently contesting for the post of vice president of Foxy from the West Zone, and we wish him all the very best. And we have invited him here specifically for his unique insights into OBGYN, emergency obstetrics, and the law as it stands, because there has been a lot of progress in dealing with obstetric hemorrhage over the past 25 to 30 years. Thank you, Shriman. I think I'll start my slide share now, if you don't mind. Yeah, Dr. Jairani is here. I can see her. Welcome, madam. Thank you so much for joining in. The problem is that when you have too many panelists, you can't fit them all into one screen. So you can't see their facial expressions sometimes. So apologies for that. So are my slides visible?
Yes.
Great. So I would request that everybody else who's not part of the panel to please keep your video off, and we will just have the panelist and the moderator on. I think the panelists have already been introduced. So welcome to this panel. And I usually like to start by quoting a very famous statement from one of our past presidents of FIGO, Professor Mahmoud Patallah, who is from Egypt. I had the good fortune to meet him about 13 or 14 years back when Sir was the FIGO president, and he had visited Mumbai for one of the conferences at which my teacher, Dr. Nuzar Sheriar, was the organizing chairperson. And here I quote that women are not dying because of diseases that we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. In the 21st century, for any woman to die of obstetric hemorrhage or peripartum complications is something which should never happen, no matter how resource poor an area you may be practicing in, whether you're in sub-Saharan Africa or a small primary health center. I always like to think that postpartum hemorrhage, typically 1970s Hindi movies, if you see, the opening scene is how this child became an orphan or he lost his mother. The doctor comes out of the delivery suite and says, I'm sorry, we couldn't save the mother, we saved the child. That is a scenario which should only be in movies from the 70s and 80s, and that should not be repeated anymore in modern life in the 21st century. So I've structured this panel a little bit like this. We look at the current scientific evidence, we go through some of the guidelines from the international bodies, and through all our experts, we take strategies for success. TPH and APH is something which all of us are pit pat with. So I don't think there will be much to talk about which is new. But what I want to bring out here is through different education systems and through different regional perspectives, how some of us favor one particular methodology over the other, and through that we'll try and build consensus. So the first question that I would like to pose to our panelists, and we'll start with Dr. Kiran Gupta, madam, is, are we actually talking about obstetric hemorrhage too much? Is it something that we should only be talking about during exam time, or it should be part of a learning curriculum? in practice we don't see it all that often, and it's not as catastrophic and bad as it's described in our textbooks. What do you feel, man?
Obstetric hemorrhage, if we talk in terms of percentage, I think it is hardly 3 to 4%. But if it happens, if obstetric hemorrhage occurs, it is very catastrophic and it is very, very much morbid to the patient and it can cause the mortality also. So though the percentage is less and now the recent advances are there, many drugs are there, but still it is a topic of concern and it is a topic of nightmare for all of us, for all the obstetricians. So
I
we have to
think,
talk about
as we were just saying at the beginning, that even one case of maternal mortality which happens because of obstetric hemorrhage is not pardonable anymore, especially if it is because of a lapse on our part as an obstetrician gynecologist, or because of the institutional policies under which sometimes we are forced to practice. I want to bring Dr. Gitendra Sharma here into the discussion. Sir, here you can see the statistics that even now about 9 million cases are occurring annually as per the WHO figures. And these are old figures, I'm sure they have changed and they must have gone down now. But still, when PPH happens, there is a 3% mortality rate. Is that forgivable in a specialty like obstetrics and gynec where we rarely see mortality?
Actually, courts does not run with the standard data available. Court only see that in condition of PPH, what you have done. So how they decide that whether doctor is negligent or not, they will compare your act which you have done at the time of emergency with some other standard routine doctor. So suppose you are working in a big city, and if you are working in a small city where there no facilities of blood bank are available, so according to law of the according to circumstances, the requirement from you as a gynecologist are different. So negligence is defined as something which normal prudent doctor will do in that circumstance. That much if you have done, then you cannot be held negligent. So suppose you are in periphery, then what is required from you, that suppose some PPH patient has come, so you should take two Vigo 18 number on both sides and you should pack and transfer to the tertiary center as early as possible. And if you are supposed to working in a big city, then even it is desired from you that you should even go up to obstetric hysterectomy and you have to manage all FFPs and everything. So requirement desire from you are different according to the circumstances, according to the standard, according to the place. So there are so many things which are desired. So suppose you have not done anything, even then if your circumstances are such, you may not be held liable. And suppose you have done everything, but even if you have not documented it properly, then you may be held liable. So again, documentation plays the main role, that what you have done. So whenever there is a case of PPH, it is always advisable to document the steps taken by you one by one. That first what you have tried, so massage was given, then packing was tried, then different kind of stitches were tried, uterine artery ligation was tried, interiliac ligation was tried, and last but not least, if you have taken decision for obstetric hysterectomy, then you have tried. So simultaneously you have done all the tests for seeing that whether patient is going into DIC or not. So all kind of investigations whether you have done or not. So these are the things which law believes that whatever is mentioned in textbook, standard textbook, that is to be followed by the doctor.
Thank you, sir. I think you have highlighted here two important points. One is that if you diagnose a condition, at what point you diagnosed it, that has to be documented. And number two, what were the corrective measures and steps that were instituted by the entire team that requires to be put down on paper along with the date and time. What happens is typically when we encounter an emergency, we all start running around behaving like headless chickens, and unfortunately we forget what is the role of each person in the team, and we'll come to that in the next few minutes and we'll discuss that in detail. Thank you, Dr. Gitendra Sharma, sir. So we'll start by discussing what is the prophylaxis and prevention of PPH. For this, I would like to bring in Dr. Atul Padmawar, sir, and ask him, sir, is there any way we can predict who is going to have PPH?
Yes, sir. Good afternoon, sir. PPH is the excessive bleeding during normal delivery or cesarean section. By definition, if the blood loss is more than 500 ml in normal delivery yeah, 1000 ml in cesarean section, then you called it as a PPH. But in my view, if any patient in any patient if develops a lot of bleeding with unstable condition, yeah, there is increase in the pulse rate, yeah, there is a hypotension, then we call it as a PPH without taking consideration into the loss of blood. And prophylaxis of the PPH start with the history taking of the patient. We can identify the factors in the patient uh, that can result into the PPH, like age of the patient, if the patient is multiparous, if the patient is multiple pregnancy, like twins pregnancy, triplet pregnancy, they are predisposing factor for the PPH. Then second, third is the body mass index, that is if more than 35. If there is previous history of PPH, then their patient can go for the PPH in this pregnancy also. Then polyhydramnios, any pathology that increases the surface area of the uterus, that in that patient PPH is commonly happening, like fibroids, multiple pregnancy. If the patient goes in precipitate labor, there is the chances of postpartum hemorrhage, placenta previa, and accidental hemorrhage. All these factors, these are the predisposing factors that can precipitate the PPH in the patient.
So there's a long list of conditions. In fact, if you ask me in obstetrics gynec, just like in general medicine, when a student is asked what are the 50 causes of hepatosplenomegaly, probably as OBGYNs, we can also name 50 conditions where APH and PPH can occur. And that is highlighted in both the WHO guideline from 2012, which has recently been updated, and also the RCOG Green Top guideline number 52, which was published in December of 2016. Identifying a patient who is at high risk for PPH is a topic of a lot of study or a lot of research, because if you can identify this patient before it happens and you can prevent it, then probably a lot of the issues that we deal with, like mortality and other complications, dealing with patients' relatives, and so on and so forth, can be actually addressed. If you look at the RCOG guideline, it refers to four distinct groups, that is, tone, tissue, trauma, and thrombin. And under each of these four T's, as they call it, different indications for us being vigilant are actually put up there in great detail. It's beyond the scope of today's discussion to discuss the entire laundry list, but I just wanted to highlight that this is clearly documented in all of our textbooks, which we have studied 25, 30 years ago, and subsequent recent guidelines are also there, which clearly show you the entire list. And if your patient has had any of these and you missed it, then tomorrow you could be held as negligent. So it's important to know this background. Of course, thrombin and idiopathic thrombocytopenic purpura and all those rare cases are not so commonly encountered in Indian patients. But definitely, if it was a twin, if it was a placenta percarita or accreta, uterine inversion or rupture, then that's not something which we should be missing. I want to bring in Dr. Pooja Bandekar here into the discussion. She's somebody who has tackled not one but two entire units in a busy maternity hospital, which is a teaching institution like Vadia Maternity Hospital. And I want to ask her that usually when we were residents at that time, we used to have something called as a pink card system. So there is to be a PC anemia, there is to be a PC elderly primigravida, and so on and so forth. Is it possible to give a PC PPH to anybody? Is there any way that we can say, okay, PC suspected, maybe query, maybe prone for PPH?
No, sir. We can max give a pink card for all the predisposing factors, but it is very difficult to diagnose. The major cause of postpartum hemorrhage is uterine atony, the most important cause, and it is absolutely impossible to diagnose which uterus is going to become atonic before the delivery of the baby, because you cannot predict which lady will land up with a prolonged labor, or which lady will require what amount of tocolysis, or which lady will require what amount of uterotonics for the labor to progress, which lady is manifesting with clinical chorioamnionitis or a subclinical chorioamnionitis, and each one of this has its own share in either improving the tone of the uterus or in further spoiling the tone of the uterus. So you cannot predict which lady will end up with a uterine atony before delivery. So difficult to give a PC-PPH.
So
So
absolutely
I would
right.
like to say, sir, that my personal experiences, what happens is we fail to recognize PPH. This is what I have realized. One, and secondly, in teaching institutes, something which has always dreaded me is the hierarchy. द हाउस ऑफिसर फीलिंग कि मैं बॉस को कहाँ डायरेक्टली बता दूं. कभी कभी यूनिट हेड घूमता रहता है, लाइक आई वाज लाइक अ वॉन्डरिंग गोस्ट, especially when I had 2 units. I used to be just in and around the labor room, but sometimes the first poster would get scared to tell me. So I feel that it is extremely important to recognize PPH. You have to recognize that the lady is bleeding, not just wait for the pulse to get thready or low volume or for the BP to fall. And once you see PPH, you have to start acting upon it, including calling for help. It just does not matter whom you're calling, but you should have somebody with you and you should start acting on it immediately.
Perfect. So by the time the SHO informs the registrar informs lecturer,
patient is
lecturer
already
informs
lost too much.
AP, and by the time it comes to head of unit, after maybe another 1 hour, precious time has been lost. I think that is
Yes.
very well conveyed. Thank you so much, ma'am. And I have just put this slide up because WHO themselves says that the primary cause in more than 80% of cases is uterine atony. And I'm very fond of saying this in a very colloquial fashion that no patient comes with a sticker on her forehead saying that मुझे PPH होने वाला है, मुझे बचाओ. You have to
Sir,
take
एक और चीज
universal
मैं बताना
precautions.
चाहूंगी,
Yeah.
because both of us are students of Dr. Kaizad Damania. Dr. Damania used to give us little principles which used to be extremely important in obstetrics. He always used to say empty bladder. So when the baby delivers, if the patient has not passed urine or if we have not emptied pre-delivery, at least after delivery of the baby, we should empty the bladder, because draining bladder achieves the normal access and helps in the retraction of the upper and the lower segment.
Thank you,
So
ma'am.
an
Thank you
empty
for
bladder
reminding me
also
of the
helps a lot.
textbook lessons and the taking me back 25, 30 years to my formative years. If you see more recently, ACOG has given these different tables which are there. They've made some attempt through their Safe Motherhood initiative to try and give people a ready reckoner, especially if you're dealing with paramedical personnel or if you're dealing with very junior residents and they need something like a ready reckoner. These are easily available. You can print these out, you can hand these out amongst your students and your trainees, and that will make their job little easier, just like the RCOG 4Ts. So I want to bring Dr. Pooja Khitwani back into the discussion and ask her, Madam, in your scenario where you practice, what is the drug of choice for initial management of PPH? I'm not asking what is recommended in the textbook. I'm asking what do you use in clinical practice?
So we use oxytocin as the initial management. First and foremost is the oxytocin we use. That is to be used even prophylactically, and the dose can vary. Like when we use it in prophylaxis, we use 10 units more commonly, IM or IV. But if we use it in management, we can increase the dose. But the first and foremost is the oxytocins, and then we go for other uterotonics, which are there, all the 4 other kinds.
In the good old days, when we were students, we used to give methyl ergometrin left, right, and center to everybody. Probably the issue was that the oxytocin which we had in the labor ward, was standing there at room temperature at 35 degrees, and we didn't know whether it would act or not. So preferentially, we were giving methyl ergometrin. Now, because we are in private practice, we have a refrigerator. We know that the quality control is there, temperature is maintained. We've switched over to oxytocin, most of us. But if you look at 25, 30 years back, it was a totally different scenario. Dr. Mangal Rathi, ma'am, I want to ask you, is there anything new that is now recommended? What about this misoprostol? Do you think it's effective? Do you think it should be used as a primary agent?
Yes, it is. It is much more effective. First and foremost, it is very cheap, and no special training is required for giving this misoprost. We can use this orally, vaginally, rectally, and sublingually. All these way anybody can give it.
So, in your
So it is
experience, would you
yes.
recommend it as a primary agent where IM injections cannot be given, say, in a primary health center or a small trained nurse is delivering a patient? She doesn't know how to give IM injection. She has no facility to store oxytocin at the right temperature. Do you think in
Yes.
this particular
Yes, yes,
scenario?
yes. Yes, yes. In this scenario, misoprostol is very useful.
Yes. So when you have traditional birth attendants actually doing these kind of deliveries in the periphery, it has
Yes,
been
yes.
seen even in sub-Saharan Africa and parts of India as well that misoprostol can sometimes be used preferentially, and this is
Hmm.
given 600 micrograms orally,
Yes.
and for prevention it is highly recommended. Now we come to a very controversial
Recommend.
thing
Yes.
which nobody admits, including I. I have to be honest and say that we get bored of waiting for the placenta to deliver, and we do some or other cardi and try to deliver the placenta early. Whether it is with uncontrolled cord traction, whether it is with manual removal of placenta, I can't even tell you what sort of stunts sometimes some people do, including myself. I have to be honest and say that I'm not blaming somebody else. Even I sometimes get bored. So I'm going to ask Dr. Jairani Kamraj what are her views on this so-called controlled slash uncontrolled cord traction?
Absolutely. I agree with you, Pratik, that it is always go by your teaching. So when you really want to prevent a PPH, never be hasty. In delivery, this is the most important step that you should give enough time. At the same time, a careful monitoring time to see all the proper stepwise changes or the happenings that is happening in the third stage. That's very important. You should be very careful. You should always go by teaching. You can do the controlled contraction, which is very important. Never pull on the thing and don't try to go hasty. That will make you land into trouble. Even in the C sections, in cesarean also, we always recommend, even for the juniors, always go wait till the placenta gets separated, even in a cesarean. So always a controlled contraction, give a proper timing and see for the signs of separation, and then you proceed, will prevent the maximum blood loss for the women and try to make her much more comfortable during the third stage without much complications.
Thank you, ma'am. I think that is very beautifully conveyed, and WHO also echoes this that where skilled birth attendants are available, only there you do controlled cord traction under supervision. And this is not something which should be done where you don't have facilities for putting in an IV line or you don't have access to oxytocin very easily. There is some controversy today about when do you clamp the cord. In the old days, we used to do immediate cord clamping. Dr.
Hmm.
Kiran Gupta, ma'am, what do you think? Should we wait for some amount of maternal blood to flow to the fetus and then do cord clamping, or should it be done immediately post delivery? Is it different for vaginal birth, different for cesarean section? What are your views on the topic?
Cord clamping can be delayed if the patient is not having PPH or something is not there. We should delay the cord clamping so that maternal blood, some amount of maternal blood can go into the fetus. So ideally the cord clamping should be delayed, but there are few conditions where we have to do the early cord clamping. Like if it is a patient of placenta previa or the baby is exfixated or preterm baby is there, like in RH negative also, we have to do the early cord clamping. Otherwise, generally we delay the cord clamping so that the babies get advantage of the maternal blood.
So obviously, if there is heavy bleeding happening, then waiting for 1 to 3 minutes for what the textbook recommends today could make the difference between life and death for your mother. So be judicious when to apply what is textbook teaching. The textbook may say 1 to 3 minutes, but then if the patient is actively bleeding or if the baby is compromised, needs resuscitation, then it's not something which we should do. Dr. Mangal Rathi, ma'am, is
Yes.
uterine massage for prophylaxis a good idea? So I'll just give you a clue. In the old days, this was called as the Creedy's maneuver.
Yes,
Do you think?
uterine must. Yes, yes, yes.
Go
It
ahead.
is a good option. It is a good option to prevent PPH, sir. Because when deliveries are performed by DICE and anybody, they are not knowing for giving injections. It is the best way to prevent bleeding.
So actually, what the WHO says is that for prophylaxis, you don't recommend it. If PPH is happening actively, then by all means you do a bimanual massage. You just assess the uterine
Yes,
tonus, but preferably don't try to do
yes,
uterine massage because that may actually cause more heavy bleeding. We've already tackled this issue about cesarean delivery, when to do cord clamping and how
yes.
to deliver. Let's go to the first case now that all our panelists are warmed up. This is a 27-year-old primary gravida. It's a book delivery, uneventful pregnancy. Like I said, she didn't come with a sticker saying that I'm going to have PPH. Delivered spontaneously, FTND, 3.2 kilo baby. That was 30 minutes ago. Now the placenta is not delivered, 750 ml of blood loss. You are the consultant on call. The SHO has informed the registrar has informed you and Dr. Jairani ma'am. How would you step by step approach this patient and how do you intend to activate your entire team? What should they be doing?
So first, when I get the call from my junior resident, the first thing I will ask to do call for help because this is almost 750 ml. Half an hour has gone. So there is some problem which is happening. The placenta is not being separated. So you have to keep the theatre ready, your anesthetist, your intervention team. All the team has to be alerted. And second, you have to see for the ABC, the vitals, your airway, monitoring the women and see for the vitals are very important, has to be instructed. Call for all the blood products to be arranged, at least 750 ml. So you expect another 500 ml to loss because during the expulsion of your placenta, or you may need a surgical intervention. So I'll ask for 1 or 2 units of blood to be kept ready and blood products to be reserved. And then when I reach the place, these all should be done as we reach. Once we see, very important, as firstly insisted by Pooja, that we should see whether the bladder is empty because sometimes a distended bladder can produce a improper delivery. The placenta would have separated, but still the placenta will be there down with the bladder being compressing. So I'll make sure that the bladder is empty and then see whether there is any signs of separation. And then once the team, anesthetist, everybody is ready, we will try few simple methods. First, we'll see whether there is a separation, see whether it can pull a slight traction, see whether there is anything. Sometimes it is a detached placenta, maybe there lower in the uterus, the internal os may be tight, so maybe it is there in the lower part. We just put it and pull it out. We can even use an ultrasound to check whether it is separated and seeing in the lower pole. That is very important. So then if it is not separated, then probably you can try when the help comes. If it is a controllable blood, you are using all your monitoring, fluid replacement, monitoring her vitals, arranging for everything. You can give an oxytocin inside the umbilical cord. You can give 20 ml of 20 units of syntocinon mixed in 20 ml and saline. You can inject into the umbilical vein, and see. Sometimes it can help the placental separation also, because we have a study done in our patients, especially in the twins, injecting in the oxytocin in the umbilical cord and calculation of the blood loss. Definitely there is a 1/3 blood loss is being reduced when you inject oxytocin intra umbilically in the umbilical cord. So we can try that, because as we try, it can help for a separation to happen. Even if there is no separation by that time, then you can shift the patient inside the theatre. That's very important. Don't meddle in the labor room, because otherwise you will be increasing the blood loss, making the person still more go for the pain. And when you manipulate, she will have a lot of pain. That itself will make her go for a shock, pain shock. So shift her inside the theatre, check her all the vitals and keep everything ready under anesthesia if possible, or at least with the help of the other people. Put your hand and see whether the placenta can be removed manually. If you have an ultrasound, you can definitely see. Definitely an obstetrician should prevent this, because a placenta accreta or increta could have been identified even earlier in your routine antenatal scan. When there is a predisposing factor or a risk factor, you can definitely be sure that this placenta is not having a proper separative line. If so, you have to be anticipating the placenta. If there is a normal placenta, even with that, if it is not getting removed proper, you have to do a manual removal, preferably under anesthesia.
Thank you, ma'am. So I think you've covered a lot of points here. I'll just reiterate them for the sake of the audience. One is that there has to be a team approach. Number two is that everybody has to be coordinated. Each person on the team should know what his or her designated role is, for which we need to have obstetric skill drills. They should be periodic so that we refresh our memory. And when the actual emergency occurs, then we all behave helter skelter, everybody is confused. And Dr. Atul Padmavar, this is one of the obstetric hemorrhage checklists which the ACOG has given. Do you use something similar to this, sir, in your practice? I want to bring you in and ask, how is your unit handling these kind of patients?
Sir, we
is
have our yeah.
yes, sir.
Somewhat modified in that this checklist. We are using all these points in our checklist for PPH antepartum hemorrhage patient.
Thank you, sir. I think all of us are treating PPH, but sometimes a mnemonic like this called hemostasis. I'll just quickly go through this. H is call for help. A is assess and resuscitate. E is establish etiology. Like Dr. Jairani pointed out, you need to know what is the cause in this particular patient of the retained placenta. What is the reason? Has the cervix closed? Is the placenta trapped inside? Has it already separated? M is for massage the uterus. This is active BPH, so you need to give bimanual compression. O for oxytocin. S is shift to theater, as she rightly pointed out. T is tissue and trauma. That is the four T's which you need to exclude. And then we'll come to the rest of the ASIS in the subsequent part of this panel discussion. So I think we've covered a lot of ground. What I want to ask my panelists now, and especially Dr. Pilja Khetpal Sevani, madam, what is the IV fluid of choice? Would you give blood directly? Usually, it's not available immediately. So, what would be your choice of IV fluid in this patient? You've put two large IV bore cannulas. You've taken your blood for grouping, cross matching, and all the other investigations that you want to do. Now, what would you start from this patient? Colloid or crystalloid?
First of all, we'll start with crystalloids. First of all, we'll start with crystalloids, and then along with that, if at all the patient is still bleeding and we are not able to arrange for a certain period of time for the blood, then we can go for colloids even.
Dr. Mangal Rathi, ma'am, would you agree?
Yes, I am agree. We are always start with crystalloid and then colloid.
Okay, here is where I tend to differ from what is given in the textbooks. By the time you, as the head of unit or the consultant, are informed, it's already more than 45 minutes or 1 hour. The patient has bled significantly. And by that time, the crystalloid has already been given by the nurse or the junior resident. So by the time you reach, it's
Yes.
time for colloid.
Yes.
So though the textbook
With the
says you start with
In
crystalloid,
this situation, it is like we should go
by
for
the time you as a consultant reach there, all the basic measures have been done. And now it is time for you to start your hemaxil or your plasma expander and mobilize the blood. In fact, I remember when I was a resident in Vadea Hospital 25 years ago, there was a unit which used to have a lot of patients who had PPH. For some reason, that particular day emergency used to get a lot of patients referred who had PPH. And then there was one resident who was constantly always running to the blood bank and getting blood. So one person was specially designated only as a blood mobilization officer. So something like that needs to be kept in the back of our mind. And of course, as the case goes on and gets worse, you need to give FFP platelet concentrates and you need to make these arrangements. In fact, addressing this particular issue, there is an organization called as NATA, which is the North American Network for Advancements of Patient Blood Management. This is their guideline. It's beyond the scope of today's discussion. But if in case you want to see what is preferred, what proportion you give FFP, platelets, and your plasma expanders, this is a good guideline to go through. And it would be of interest to your students as well and your trainees as well. So we've talked about retained placenta. We are already 30 minutes, 35 minutes into our panel discussion, so I'm not going to talk much about the active management, which all of us are aware, oxytocin, ethalogometrin, and of course, prostaglandins if necessary. The next steps are going to be a little rapid fire, and I'm going to direct them to all the panelists. One single sentence answer for each of these questions. Does external aortic compression help? Dr. Mangal Rathi.
Yes.
It does
It
help.
definitely helps.
Yes, definitely it helps. But the problem is that this is defined for women who are very thin, lean. There are very few patients today in the 21st century who are thin and lean, and where you can try and compress the aorta against the vertebral column. So, theoretically, yes, it's a good answer. In practice, whether we can actually do it or teach it to our residents, that's a big question. Crystalloid or colloid is already covered. Dr. Pooja Bandekar, tranexamic acid, yes or no? And how much, if yes?
1 gram.
1 gram IV
Yes, 1 gram IV.
as a bolus or slow IV in an infusion?
I give it as a bolus.
As a bolus. And how often can you repeat it? How much can you give? It can be
I
a
can
life saving measure. You can
It
give
is
it up
a
to
li-
4
yeah,
grams
yeah.
in 24 hours. and you can
Yeah.
repeat it in case the
I
first
repeat it
dose.
if required after 6 hours,
Yes.
4 to 6 hours.
Dr. Pooja Sevani, how do you do uterine massage? Only abdominally, only vaginally, bimanually, none of the above.
The uterine massage is done bimanually only, but bimanual compression is different than the uterine massage.
Yes.
And we go for bimanual compression even for compressing the uterus to compress the anterior and posterior wall of the uterus and show the vessels that compressed. And so it helps to stop the blood for a while if we are reaching up to the operation theater or we want to do something active. Up till then, we can go for bimanual compression of the uterus.
And to a certain extent, it will help to evacuate the clots also which are forming and help to restore the tone in the uterus. Dr. Jairani Kamraj ma'am, have you heard of this term obstetric shock index?
Yes,
Do
but
we use it in clinical practice or it's only for the theory?
it's only for the theory. We
Okay,
cannot
so
use
this
it
is something which even I learned quite late on, and
Yeah.
this is the pulse of the patient
Examination,
divided by the systolic pressure. The normal value should be less than 0.9.
9.
The moment it exceeds 1, it means that this patient needs colloid and needs active measures. She needs urgent intervention. So, if you want your resident to give you one single piece of information on the phone when she is informing you in the middle of the night, you simply ask, what is the obstetric shock index? If it's 1 or more, then you need to rush there ASAP and ensure that all the starting measures, which you beautifully elaborated, are already put in place, and then you will go ahead and intervene as per the necessary issues that are there in that patient. There are some things which are described in our textbooks. I don't know how often we actually use them, and this slide refers to them. And I'm going to ask Dr. Atul Padmawar sir, have you ever done intrauterine packing? Do you think it helps?
Yes, sir, it definitely helps. In cases of atonic uterus which is not responded, in that cases as a primary line, you can use as a intrauterine package with the balloon, yeah, otherwise with the gauze piece.
So, which would you prefer? Is it something like a condom catheter, which is described by Professor Shivkar, or do you use a Bakri balloon,
we have this condom catheter.
which is most easily available and it's cost effective also, probably, as compared to a Bakri balloon, which is much more expensive? Dr. Pooja Bandekar, any experience with this pneumatic anti-shock garment? A lot of WHO guidelines show this, especially in low resource settings, where you do a medical phlebotomy by inflating the cuff in different parts of the body and try and restore the blood pressure and the venous return back. Do you think it would be of any help, especially if it's somebody from a periphery being transferred to a central teaching institution?
I personally have no experience with it.
Anybody on the panel has seen this being actually used?
I can talk about
Yes,
it.
ma'am. Please go ahead.
There have been a lot of, this pneumatic anti-shock garments have been very much used in our Tamil Nadu, many peripheral centers, in the PHCs, in all the peripheral maternity centers. They have this pneumatic anti-shock garment, which is a very much useful for the patients to shift. That gives you a lot of time and save the patient when you use this, and it has been provided in all the primary health centers, this pneumatic anti-shock garments, where they have it's available, and every VHN, that the village health nurse, have been trained to how to use it, how to put it. As she keeps the ambulance ready, shifting the patient, she can put it and give her fluids and shift, and this prevents the maternal mortality and morbidity to the highest level. So definitely, we in Tamil Nadu, we are using this as very, useful. Though I'm not using, because I'm not in the center, but we have been to the very many centers to talk about it, and we have showed them, and they are using, and every center is provided with that. Definitely, it's a blessing.
I was talking to our Vice President South Zone, Dr. Jayam Kannan, who has nearly 50
Yeah.
years of experience.
Yeah,
she was the one who told me that she herself has trained ASHA workers and primary health center workers. And almost every PHC in the South now has one of these kept as an emergency life-saving measure. How much they use it, we of course don't really know. Since you're also from the South, we have these two instruments which are actually India's gift to world obstetrics, and that is the vaginal clamp and the suction device. One is devised by Professor Paili and the other is from Dr. Panikar. Can you tell us something about these instruments? Because I don't know how many of us from Maharashtra are aware, and I want to draw light on this particular two instruments which have been devised in India?
So the Paniker's suction cannula we have, and it is just once you suck it, once you put it and suck it, it causes a collapse. It produces a negative pressure and cause the lumen to get collapsed, and that suction will maintain the pressure inside, so that as we compress, it is like a compressing the anterior and posterior wall, so that the cavity is occluded. Just what the Bakri does, it's occluding the vessels, whereas this will have a suctioning effect on the vessels and they get collapsed and both the walls gets occluded, and that prevents the bleeding, as well as it increases the time for the clotting to happen also. So definitely both works in the same way. Suction is inside. Vaginal clamp is just you put it is occluding both the
Uterine vessels.
Yeah, uterine vessels, both sides, to clamp it so that the vessel blood flow is reduced. But suction cannula is just like a little difference with the Bakri, but has a very good impact. The Paniker's cannula is very good.
So these are basically primary measures which even a resident can undertake before the patient is wheeled into the theatre for temporary reasons. Again, the vaginal clamp is not recommended by the inventor himself for longer than 30 minutes because it could cause irreparable damage to the ureter. Let's go to the second case. This is a 34-year-old primigravida. She's conceived on IVF treatment, previously treated for intrauterine adhesions. She's had hysteroscopic adhesiolysis twice. She has presented at 35 weeks to the accident and emergency pulseless. She is hypovolemic. Cardiac activity is present, but there is fetal bradycardia. I don't need to tell you, this is an antepartum hemorrhage. What I want to ask Dr. Pooja Sevani is, how should we proceed? What would be your next steps?
The patient is pulseless. We should first go for ABC of the patient.
Correct.
But along with that, we should start all the measures of the hemorrhagic. Now we saw the list. We should go with all the investigations. We should start the 216 gauze IV cannula, everything. But also we are seeing that the fetal bradycardia. We are seeing fetal bradycardia, and even if we go for the one which is described pneumatic anti-shock garments, we can go with that also if at all it is available with us. Then we can.
Let's cut to the chase. I'm going to ask you a leading question now. Since we've already discussed all these measures previously, we will not repeat them here. This is a traumatic PPH. This is query rupture uterus or an abruption. You have to save the life of preferably both the mother and the baby here because there is fetal bradycardia. So how is this surgery different from a routine cesarean section that we are going to do?
I was going to tell this only that until and unless we go with that, we can prevent more bleeding by using that anti-shock garment, and also along with that we can go for this perimortem cesarean section, which is now known. Perimortem cesarean section is helpful for both, would be helpful for both because it will cause maybe the baby will survive, and also it will cause decrease in the it will release the pressure on the IVC, and so the blood will come, and along with that if we are using that anti-shock garments and with that blockage we can increase the blood flow, and so the patient may survive and even the baby can survive.
Okay, so from one puja to the other puja, madam, this patient has come to you in emergency. Luckily you are there on call. You have opened the patient by a midline vertical infraumbilical incision. There is a huge amount of blood in the peritoneal cavity. How are you going to deliver this baby? How are you going to identify where there is a rent in the uterus, and how do you intend to repair it? Very practical question.
If it's a rupture, and if I will see what's the location of the, this looks like a rupture to me. So I'll see the location of the rupture. Most probably this rupture.
Kahi disat nahi hai. There is 3 liters of blood in the peritoneal cavity. The baby is probably swimming around in the peritoneal cavity.
So what will you? If the baby is swimming there, I just take out the baby. I have already activated the NICU completely. So I hand over the baby to them. And once I hand over the baby, I try to localize the ruptures. If the rupture is repairable.
So do you deliver the uterus? Do you not deliver the uterus? I'm asking very stupid questions, but they are practical questions which are of help for all of us.
I will have to deliver the uterus.
So you deliver the uterus. Very good. You identify where is the rent.
Where all the ruptures are and where they have extended to.
Correct.
And whether they have before, if there is 3 liters of blood loss there could be extensions of hematomas laterally, inferiorly,
Correct.
wherever. So
Absolutely.
basically I need to see whether the uterus is, yes ma'am.
No, I just want to interfere. It's very difficult to deliver the uterus at that time, Pratik, because
I know.
you
But
can't
yes, they
have
have a
any
midline vertical, no?
anatomy you cannot identify. As she said, your broad ligament maybe they are torn there, because this Asherman's syndrome has a problem of placenta accreta increta may be associated, because what causes this thinning is maybe the placental position. So if there is a rent there close to the placenta, it is very difficult for you to go through the rent, get it done. So baby will not swim. There may be a rent. You may be having a blood. You have to be little careful. See the extra location and cut an incision and take out the baby. Unless if the baby is pooling outside the cavity, means the baby would have been IUD. Definitely it would not have been a blood. Baby will not be swimming inside. There will be a blood inside. You have to visualize. Try to make a proper incision as per the schedule, and then don't go through the rent, because the placenta will be sitting over there. That is a very important one. Why there is a scar? A dehiscence happening, because in Asherman's there is always an increased risk of placenta percreta, increta,
Correct.
everything.
We'll come to
So,
percreta a
so
little
that is
later.
the cause for this getting into a rupture, because it
Yes,
is
ma'am.
not the disease process, it is the placenta that is causing. So where there is a rent, there will be a placenta sitting behind, and it is difficult for you to save the baby as the
Or it
mother,
could
because that
also
will
be
be,
just a localized
you have to
weakness of the
listen
uterine musculature.
proper and then take the incision, deliver the baby, and then look into the rent.
True.
Not through the rent, you should do it, because that will land you into a still more problem.
So, Dr.
And
Pooja,
definitely you cannot
you have
deliver the baby.
identified the rent,
Mm.
you have localized it, you put your Alice's forceps on it, you are trying to arrest the hemorrhage. How would you proceed with your stepwise devascularization?
If the rent is repairable, I'll try to repair the rent. If it's not a repairable rent, then for devascularization, uterine artery, internal iliac anterior division, uterine ovarian, internal iliac, and if nothing helps, then to consider, after ruling out placenta, increta, percreta, etc.
Correct.
Then
So
to
I think
consider
it's
obstetric.
important to have a level head, to have a good assistant there. You have a good nurse who keeps track of the blood loss, an anesthetist who replenishes fluid and colloid with blood in a timely fashion. That teamwork really helps. And having a well oiled, well drilled team will ensure that you are able to save this patient. I'm going to ask Dr. Mangal Rathi, ma'am. During our undergraduate and postgraduate years, we were taught all this internal iliac ligation business. How many of us do it actually in clinical practice anymore today? I think it's a lost art. We are ourselves forgetting it, leave alone teaching our students. We have ourselves lost this art. What do you feel?
I have also not done any time, sir.
Yes, Dr. Atul Padmavar, sir.
Yes, sir, we are doing it. We are doing it as it is a periphery hospital, and there are a lot of patients from periphery, and they are coming in the grave conditions, just serious condition. So in that situation, we have to go for the internal iliac artery ligation with the help of surgeon.
Thank you, sir. I think there is one important question which nobody ever asks, and this is a practical question which I have asked many times, and everybody gives me a different answer. Since you are doing internal iliac ligation, sir, would you preferentially do an internal iliac first and then do your stepwise devascularization, or when your devascularization is failed, then you go for internal iliac?
Sir, when our stepwise devascularization phase, then we can go for the internal iliac artery ligation. Yeah, directly in cases of traumatic PPH, when there are vaginal lacerations, yeah, there are tears that can't be managed with the stepwise ligation, then we can go directly for the internal iliac artery ligation.
So that is why I sometimes feel that your aortic compression and your internal iliac ligation in the first 5 minutes when you open the patient is more likely to save the patient, not only her life, but at least 1 extra liter of blood loss. Like you said, in a patient with traumatic PPH, it may be very difficult to identify the source of the bleeding. There may be multiple bleeders. So, if you go at the source and identify it and tackle it, that's why learning and relearning this lost art, I think, will help all of us. And of course, we need to convey it to our students as well. Coming back to this new concept of B-Lynch sutures, Cho sutures, Heyman sutures, I want each of you to tell me about your practical experience, whether you've used them in clinical practice. There are nice textbook pictures here. Dr. Kiran Gupta, ma'am, could you start, please?
Yes, ma'am. Yes, the B-link sutures I have used, but not the other type of sutures. And B-link sutures have really given good results. Like
And you
if
feel that they are life saving and they are uterus saving also in clinical practice.
yes,
So
sir.
all of us should know them.
Many times they have proved to be life-saving. B-link
Thank
sutures.
you. Dr. Pooja Sevani?
Yes, sir. More commonly during my PGR, but now here we use tamponade more.
So you have used them at some point in the past and you would recommend their use wherever there is expertise
They are
available.
useful.
Yes.
Yes, yeah.
Dr. Mangal Rathi, ma'am, have you seen
Yes.
these Cho sutures anywhere outside of a textbook?
No, we are used only we launch.
You're
I have
using
not
the
seen this
village.
suture.
Okay. I'm going to ask Dr. Pooja Bandekar again. What is her experience with all these conservative sutures which try to restore the uterine tonus?
I have used the B-link, sir. And once or twice, along with the B-lynch, I have taken a circumferential suture as well, along with the B-lynch, just making a window in the broad ligament, avoiding the uterine, avoiding the round ligament. I have
Like
taken
the
one
Shirodkar's
circumferential.
catheter around the cervical canal.
Yes. Along with
Okay.
the B-lynch, a couple of
Same
times I have
principle.
done that.
Same principle. If I can ask you another stupid question, but a very practical question. The original B-Lynch recommends a straight needle and it recommends catgut and absorbable suture. What do you use in your clinical practice? Is straight needle available anymore in our
It
operation
is
theaters?
available.
It's
It is
available in
available,
yours?
sir. And I have always insisted for that straight needle. And I have, being Dr. Damania's student, I have used number 2 chromic catgut only
Okay.
with straight needle.
So
I have
most
done
of
it
the
that way.
times it's very difficult to find a straight needle. It's even more difficult to find a straight needle with chromic catgut, especially number 2 chromic catgut. And if you get number 2 chromic catgut, inevitably the eye of the needle is so small that that number 2 will not get threaded at all. And by
No,
that
sir,
time you are getting irritated.
no, sir, the straight needle very beautifully passes through the anterior and posterior wall. I find it very
It does.
easy to maneuver.
It does. But threading the number 2 chromic catgut into the needle itself, I
So we
think
have,
you have,
it's there, sir, it's
then
still
you are
there.
very lucky. I think most of us in private practice don't have access to a straight needle or to number 2 chromic
I
catgut.
know chromic
We
catgut
still
is
use
completely obsolete, but yes, we use chromic catgut for all the extensions, etc. And I personally have been very happy with the results.
so I think most of us in private practice are still using a curved needle because straight needles are difficult to find, and we still use Vicryl because, as I said, chromic catgut is a difficult entity in today's world to procure in the middle of the night when we are doing emergencies. The last step, of course, is an obstetric or a cesarean hysterectomy. And I'm going to ask Dr. Mangal Rathi, ma'am, where would you preferentially go ahead and do an obstetric hysterectomy and not waste time with anything else like stepwise devascularization? And how
If
would you
bleeding
do?
is if bleeding is more and internal iliac artery ligation, uterine artery ligation all fails and bleeding continues, then we have to take decision of immediate obstetric hysterectomy, sir.
Okay, so if you have a condition where it's a life saving surgery and you feel that your other conservative efforts may not help, then a
Yes.
cesarean or an obstetric hysterectomy would actually be something which is preferred before all those other steps that we discussed. I want to ask Dr. Atul Padmawar, sir, can you tell us a little bit about the steps of an obstetric hysterectomy and how it's different from a gynec hysterectomy? Is there any difference or are they the same?
Sir, maximum times we are going for the subtotal hysterectomy. We want to decrease the time, we want to save the time, and we want to take out the surface from which the bleeding is coming. So we are going for the subtotal hysterectomy. Like or routine hysterectomy, we are proceeding this, but we have to be very fast. And first, before putting any clamps, I will put a clamp over the after the dissection of uterovesical fold. I will put two clamps on other side so that the uterine artery get occluded, and then I will go for proceed for the routine hysterectomy. But the procedure should not be more than 15 minutes, and you should save the life of the patient.
Thank you, sir. So I'm going to ask Dr. Jairani Kamraj. We were always taught that when you're doing an obstetric hysterectomy, use 2 or 3 clamps for each pedicle and always clamp everything first, take the uterus out, and then ligate. Whereas in a gynec hysterectomy, it is clamp, cut, ligate. Here it is clamp, 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 cut, clamp, 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 cut, and then at the end you ligate. Do you agree with what I'm saying?
Absolutely, you're right, sir. Because immediately when the patient is showing a very drop in the blood BP, you just clamp, the BP will shoot up. Because there's no point in pumping her blood and making her bleed. So the first thing when you have a blood there, clamp first all the sites, so that will prevent the blood loss. So that even the blood what you're putting inside in your IV cannula or in a central line will just wash off away. So this clamping is very important, that prevent the blood loss and help her to improve the blood pressure as well as to retain the blood what you're giving intravenously. So important is cut, no cutting, clamping, clamping everywhere. Then only you have.
Absolutely. So, if in case you are unaware of what I'm speaking, just go and watch a Vardheim hysterectomy, which is done in an open fashion by an oncosurgeon, and instantly within 5 minutes, you will learn the simple principle of what is a bloodless surgery, and that is something which we all of us sometimes I feel need to go and watch, need to relearn, and it's inspiring to see how beautiful bloodless surgeries oncosurgeons perform. We are almost at the end of our panel. I'll take 5 minutes and finish the last case. This is a 35-year-old, Gravida 3 para 2 living 2. She has had two previous elective LSCS. Ultrasound has shown an anterior placenta. You need to do an elective cesarean because she is previous to LSCS, so I'm not going to give a trial in this patient. The question is, when is the ideal time to perform the cesarean, and what do you look for prior to posting her, and what investigations do you do? How do you counsel the patient prior to the surgery? Dr. Mangal Rathi, this patient has come
Yes.
to you. What would you like to do for her?
Ideal time is 38 weeks. I will plan at 38 weeks. Then I will first counsel her. We have to, there is a chances of rupture of uterus if patient goes in labor. We have to
Absolutely.
counsel like that to prevent PPH, to prevent, to save the life of baby and mother. We have to plan at 38 weeks. And investigations, routine investigation, ANC profile. And again, we have to arrange coagulopathy to prevent coagulation profile we should perform. And again, we have to arrange at least 1 point of blood should kept ready for any emergency. And we have to tell them the complications like bleeding.
Yes. So if you are suspecting that this is a morbidly adherent placenta, like a placenta accreta or a placenta percreta, which you want
Yes.
to identify prior to posting the patient for surgery, what
Yes.
investigations would you like to do?
Routine ANC profile, CBC, and coagulation profile.
And
These
what
three.
about the ultrasound? Would you like to do a
Yes, yes,
high
we have to.
resolution ultrasound with a senior? What is the role of MRI in such patients? Though I know it's not easily available, it's very expensive. Is it something that you would consider in a patient like this
Hey,
who's at high risk?
if previous ultrasound shows any placental position, accreta, paqueta, previa, then we can go for MRI if it is available in that city.
Thank you, ma'am. So I think this is one of those patients where you need to have a high index of suspicion. This is one patient who everything will be fine up to the time when you post her and take her on table. And then at the last minute, when you diagnose on table that you have missed a placenta accreta or a percreta, then nobody is going to forgive you for missing the diagnosis. So in today's world, where there are so many medical legal cases happening, where patients are beating doctors up, beating the not only the doctors but also the paramedical staff, breaking the hospitals, these basic investigations, like you pointed out, we must do. Take a good senior radiologist opinion. Don't let it be an ultrasound which is done by a gynecologist who is doing obstetric ultrasound. It has to be a radiologist who has done the ultrasound. Look at the scar thickness. When in doubt, please advise an MRI. And of course, when you're posting this patient for surgery, as you rightly pointed out, you need to counsel her that there may be bleeding. You need to take a proper informed consent. You need to advocate that in case there is a placenta accreta or percreta, we may have to do additional procedures on
Yes.
table, for which, of course, you can't take a blanket consent, but at least you can counsel the patient beforehand and that will sometimes save you. Dr. Atul Padmavar sir, in your experience, is there anything that we can do pre-operatively which will reduce the kind of bleeding that you will see if this patient has an acrita? Is there something you can do pre-op?
Sir, we can give the this tranexamic acid 1 gram
Very good.
before the procedure.
Okay. Dr. Pooja Bandekar, anything that you can do?
Uterine artery embolization.
Thank you. Thank you very much. I think those of us who are blessed to work in major metro cities and in tertiary institutions, uterine artery embolization has come as a major boon because of the expertise of the radiologists and the fluoroscopy procedures. For all patients like this, if you can counsel them and help them to undergo uterine artery embolization, the fetal compromise is very low, and the chances of this patient having an obstetric hysterectomy or torrential loss post surgery is much minimized, and it can be a life saving procedure in these patients. Again, I would like to say that the moment you have a placenta accreta or a percreta who is at term, please wisely assess whether you, in your situation where you are practicing, can handle this patient or not. Don't be foolhardy. Don't be brave. Don't take undue risks. Nobody is going to give you medals. Nobody is going to give you some prizes and awards. But in case there is a problem later on, people will always point out and say, you knew that in your setup you cannot tackle this patient. Why did you take it on? It's a different matter if you diagnosed it on table. You were not looking after the patient antenatally. She just came to you in labor, in emergency at the last minute. That is a different scenario. But if you already knew that there was an issue, then why did you invite trouble? I think I will close this panel discussion by thanking all of my eminent and esteemed panelists. In a very short time, we have tackled many different causes, the treatment, the prophylaxis, and different varieties of antepartum and postpartum hemorrhage. I like to leave you with this age old saying that in nothing do men more nearly approach the gods than giving health to other men, and I think for women as well, that saying needs to be updated. So I'd like to thank all of you. If there are any closing remarks or any tips and tricks which the panelists would like to give the audience who have assembled here today to listen to you, you're most welcome. We'll start with Dr. Kiran Gupta. Any tips and tricks from you, ma'am?
I think everything has been very nicely covered, and I don't think there is something to be added.
Okay,
Everything
great.
has been covered nicely.
Dr. Atul Padmavar, sir.
Yes, sir. It has covered all the things. I think the book of obstetric has come in this webinar.
Thank you so much. Dr. Pooja Ketwal.
Sir, one thing I would like to add ki, I don't know where other places it is happening or not, but here at PDMMC, we are undergoing a PPH bundle program.
Okay.
And for that, certain workshops have been conducted even. And in that, under guidance of our HOD, Dr. Pushpa Sumunshi ma'am, she undergoes a PPH bundle program where we have arranged in the labor room, in emergency, OT and all, a PPH tray or PPH bundle where we have the nucleotonics drugs, tranexamic acids, Foley's catheter, everything arranged, and even a uterine balloon tamponade. It's a
Like a PPH kit, and one person is in charge of it. Very nice. I think that's the need of the hour, having a PPH kit, having a eclampsia kit. All these things should be part and parcel and mandatory as part of our teaching and training for not only postgraduate but also for our paramedics.
I want to add.
Yes, ma'am.
Dr. Pushpa Zungare Somunshi, she is the senior and member of our society, and she is at the help at the any moment you call her, she is there for us. And
like a flying squad.
The private practitioners in Amravati for the same. Her team and her unit is working so nicely with the PPH bundle.
Thank you. Thank you so much, ma'am. Dr. Mangal Rathi, any points that you would like to convey, ma'am?
Sir, first and foremost, you have conducted very nicely, sir.
Thank you.
So thank you very much. And everything has been covered. So there is no need to add any words, sir.
Dr. Pooja Bandekar, ma'am? Any words of wisdom from you?
No, words of wisdom, sir, are that it was a beautiful panel excellently moderated by you, and I have myself learned a lot from all the eminent personalities in the panel. So I'm really happy that I was a part of this panel. It was a pleasure listening to each one of the panelists.
Thank you so much. And Dr. Jairani Kamraj, I think Dr. Gitendra Sharma had to leave. He's double booked. He's doing too many webinars these days.
So, Dr. Pratik, it's nice. You have covered everything. Only one thing I want to insist. You have to look into an anemia, which is very important. You correct the anemia because we look into all the predisposing factors like multiple pregnancy, overdistended hydramnios, everything. But sometimes we miss an anemia. Without correcting an anemia, exactly improving her iron status will help her to reduce the PPH. And even if she has a PPH, she can sustain. And the morbidity and is will be less. So always keep in mind that our patients, everybody is anemic. So correct the anemia very well so that even if she goes in for a PPH, which is unpredictable, you can save her from her morbidity.
Thank you, ma'am. I think the predisposing factors we have covered quite extensively. There are just two or three questions which have just been conveyed to me since everybody is here. I'll put it to all of you. The first is Dr. Girish Mane has written into us to say that he was the one who complimented Dr. PK Shah. So he wants me to convey that to you. You have an admirer, sir, who's listening
Yeah,
in and
thank
who's
you.
teamed into you.
Sujata sent me the message.
She sent you, is it? Okay, I just saw the message now because I was busy conducting the panel and I had not seen the WhatsApp. There's another question here, and this is from Dr. Ranjana Jha. The question is IV bolus tranexamic acid safe? I think the original question had gone to Dr. Pooja Bandekar, so I'll let you take the follow up question. Is it safe to give IV bolus tranexamic acid?
I have not had any casualty till date or any
Yeah, so
problem.
the incidence of hypersensitivity reactions to tranexamic acid is extremely rare. It's a safe drug, and in fact, it's recommended by WHO as one of the primary measures that we can use. 20 years back, it was not available in our country, which made treating patients even with DUB a nightmare for us. Now it has made our life so easy that anytime the patient calls up also in the middle of the night on the phone, you can tell her this is the brand name, take this 3 times a day, and meet me after 48 hours if the bleeding doesn't stop. The next question is from Dr. Hema Patel, and she is asking in the case of Asherman with a query near term rupture uterus, what would be the treatment? I think we've covered all that in quite great detail, so I will not repeat that here. Dr. Milind Kolwalkar, thank you, sir, for tuning in. He's from Goa. Good afternoon. His question is during Panikar's cannula suction, what are the signs that the next step should be attempted? I think from the south, you only have Dr. Jairani represented, so I'll let her take that.
Yeah, that is actually, if you see a uterus relaxation, that is one thing. When you put a cannula, you usually see the uterus contracted, your blood flow will be reduced, the cannula will be, you can see the trickling of blood. But if there is a sudden gush in the blood, in the bleeding, or if you see the uterus size getting increased, even with your suctioning and the pressure being applied proper, then this is the time that you have to resort to the next step of another other surgical. And one thing, these are all preventive measures, not, I mean, measures to keep it prolonged. But absolutely, these are not the treatment, absolute treatment. Your
So these are
treatment
temporary measures,
temporary.
like we said, which
Yeah.
we can institute while the boss is still on the way and the patient is being wheeled to the theater, just to arrest the bleeding and buy you an extra half an hour, maybe, which can make the difference between life and death. There is one last question, and maybe Dr. Kiran Gupta can take it. This is from Dr. Hema Patel. She is asking the role of classical cesarean section with obstetric hysterectomy with placenta in situ.
So we can go for classical if we are thinking of placenta accreta. Or like if you want to retain the placenta, we can go for the classical cesarean. If she's a multiparous patient who doesn't want to have other childbearing, in those cases, and it is a case of placenta accreta, we can keep the placenta in situ and we can go for the classical cesarean in those cases.
So here, if I might say, just like in gynec ultrasound, we have this concept of fibroid mapping. If in obstetric ultrasound, we can bring this concept of placenta mapping. Prior to the surgery, we can plan what incision you're going to take, not only on the abdomen, but also on the uterus, and accordingly counsel the patient that you may require a classical cesarean section, which is more associated with heavy bleeding. You may require blood transfusion, and of course, in extreme cases, it may land up with a hysterectomy. having the right counseling prior to the procedure, talking to the patient and her relatives, sometimes I feel will save us with 99% of the problems. And Dr. Gitendra Sharma is not here, but I think he will also endorse this, that just counseling your patient and her relatives will save us from the vast majority of medical legal problems which crop up in today's world. I think we've had an excellent panel. We had two fantastic speakers. And before we close, I can ask the presidents of the respective societies to give us their words of wisdom, and then finally I'll present the vote of thanks.
Thank you, sir. It was an excellent webinar today with two eminent speakers with us and a very well moderated panel by you. Total obstetric hemorrhage was covered in a single panel. Can't imagine that. All the panelists were too good, and we should anticipate PPH at any time. We should take the we should treat each and every patient very effectively, that the PPH is prevented, because PPH and PIH, these are the both the nightmares in obstetrics. We always never think that we should face such patients. So we should always be well versed with all the modalities of treatment in both the cases. Thank you, sir.
Thank you, ma'am.
Thank you, Dr. Prateek, sir. I just want to thank you that you have moderated the panel very nicely. You have covered all the points in a short course and you have completed everything. You have covered everything, and I think it is very much beneficial for all of us. And all the panelists were very good. We got a lot of knowledge and we got many things to learn from today's panel. It was really fantastic panel, sir.
Thank you. Dr. Vajanti, madam. Ma'am, you'll need to unmute yourself, please.
First of all, two lectures were too good. Speakers were too good. And panel conduction was very, very nice. Panelists were too good. Excellent webinar. Thank you, sir.
Thank you very much. If Dr. Atul Padmawar, I think he had raised his hand in between. Yes, sir.
In short answer, it's awesome only, just awesome. No other words for this webinar. But I have one question, sir. Is there a role of injectable methotrexate in cases of hidden placenta, in cases of placenta accreta or percreta?
So in case you leave the placenta behind, that is one of the options that is described. Now, for what volume of placenta, how much methotrexate is to be given is not something I am an expert on, but I will myself need to read up about it. It's recommended that you can give it as a single intramuscular dose, or you can inject it into the umbilical cord or the placenta itself. Those are the various options that you have. To what extent they are effective, when do you need to follow up, when do you need to repeat the dose? I don't think there is any universal consensus regarding that. Anybody can correct me if I'm wrong regarding this.
Sir, I had one experience. I had
Yes,
a patient.
Dr. P.K. Shah has a point to make. Yes, sir.
She was RH negative, second gravida with previous LSCS. Somehow after delivery found that her placenta was not expelled out, and it came out to be placenta accreta. Then leaving her as such only, I shifted her to PDMC unit, Punjab Rao Deshmukh Medical College. We have Dr. Smita Bijwe madam, who is working on methotrexate treatment, and she very well managed the patient. The patient was hospitalized there for a long period, and after that the patient conceived once again, and she was operated. She had a full-term pregnancy after that also, and she has done a lot of patients with methotrexate in PDMC unit.
I think I can only say that God is great. No matter what we do, somehow He finds a way. Somehow He finds a way and He helps us. Yes, sir, Dr. P.K. Shah, you had a point to make, sir. You had raised your hand.
Yeah. Now, we have published a series of 32 cases of morbidly adherent placenta, and majority of them were treated conservatively. Hardly 3 patients required obstetric hysterectomy. In all these patients, we had uterine artery embolization, classical C-section or transfundal. We removed the baby and left the placenta inside, and we gave, after about 3 days, after doing all the investigations for giving methotrexate, we gave 1 milligram per kg body weight methotrexate to these patients. And we followed up, we did not discharge the patient till all the parameters, RFT, LFT, hemogram, WBC, everything was all right. And we had fantastic results, let me tell you. Only thing I want to say is that methotrexate can be given 1 milligram per kg body weight. Do not repeat it. You have to follow up the titer of beta HCG and you have to follow up with ultrasound to see the volume of placenta. And you can do it every 3 days, every 4 days, and see how it is decreasing. And what is more important, I want to tell you is that during this particular experience, we had two patients who were diagnosed as morbidly adherent placenta and placenta percreta involving bladder. So we did classical, remove the baby, cord was cut next to the placenta. And when we finished everything, and we normally do per speculum examination immediately after C-section, the patient was pouring like a tap. We immediately opened. To our shock, there was a separate placenta inside the uterus. And this happened in 2 weeks. Two patients we had, MRI had diagnosed not only morbidly adherent placenta, it was a placenta percreta. So I think you have to rely much more on your ultrasound, color Doppler or power Doppler, and MRI should be done only for posterior placenta and where the diagnosis with ultrasound is not clear. Otherwise, don't rely on MRI for all the patients.
Thank you, sir. I think words of wisdom, and that is why we respect you so much. And in spite of your varying hairstyles, which we see every week, we are always happy to listen to you because you always teach us something new. Thank you so much, sir, for coming
Thank
for
you.
today's program. I'll request Dr. Sujata Dalvi as the other AMOG's office bearer to just speak a few words before we close this program.
Yeah, it was an excellent webinar. I must tell you, learned quite a few things. RHIC immunization, hypertensive disorder, even the panel discussion, though I didn't attend the full panel discussion, I just attended a part of it. Very sorry to tell you. But yes, but overall, it was a very informative. And I would like to thank you especially and the AMOX for giving everybody an opportunity. Thank you so
Thank you,
much.
ma'am. And I'll just close by proposing the formal vote of thanks. But there is one final congratulatory note from Dr. Sneha Buyar. Thank you, ma'am. And Dr. Savitri has a message for Dr. Jairani. You have proved that you are a Madurai student. So congratulations to you, ma'am, for carrying the torch of the South. So it's my proud privilege to present the formal vote of thanks at the end. We'd like to place on record our gratitude to our AMOG's office bearers, Dr. Nandita Palchetkar, Dr. Arun Nayak, our President and Secretary. Thanks to the chairpersons, Dr. Sujata Dalvi, our first Joint Secretary of AMOGS, Dr. Nilima Ardak, President of Amravati Society, Varsha Ghate, past President of the Akula Society, Vajanti Pathak, past President of Amravati Society. Two fabulous speakers, our past President, Dr. P.K. Shah and Dr. Murlidhar Pai. I think if he didn't have the next lecture to give to his postgraduates at 3:30, he would have gone on for another 1 hour. Don't tell him I said that. And of course, what can I say about our panelists, Dr. Atul Padmawar, Kiran Gupta, Pooja Sevani, Mangal Rathi, Jairani Kamraj, Kitendra Sharma, and my colleague Dr. Pooja Bandekar. All of you were fantastic. Hats off to you. Thank you to Bharat Serums and Vaccines for supporting this initiative, and to the TOG Science Integra team for always being there for us. Subul, Shrimon, Anuja, and Seshan. Thank you so much for all your efforts. Looking forward to seeing all of you very soon. Thank you so much, and we will meet soon in the very near future. Goodbye. Take care. Stay
Goodbye.
safe.
Thank you.
Thank you. Bye. Bye.
There is one final message from the TOG team as well. I think they want us to broadcast this. So, Shrimon, you can go ahead, please. I think this is regarding webinar simple do's and don'ts, etiquette to be followed by both faculty as well as by the audience. Muting the microphone, using the laptop when possible, attending the trial run if there is one, and of course, ensuring that you are going to be well illuminated, that you're in an area of good high Wi-Fi connectivity. Next slide. I think appropriate clothing, all of us are appropriately dressed, so that's not applicable to us at least. Lying on the bed, I think none of us do, but sometimes when it's a Zoom meeting where there are maybe 100, 150 people, then sometimes some people are relaxed in the afternoon. That doesn't apply to us faculty, so it's not a personal reflection on us. And of course, it's important for all of us to ensure that we are appropriately introduced. We introduce the other person and we speak in turn as and when we are required. We try and avoid cutting other people off and not speaking simultaneously. So thank you, Shrimon, for sharing those do's and don'ts. And I take your leave. Goodbye. Stay safe. Take care. God bless.